Okay. Good evening, everyone. A very warm welcome to all our distinguished faculty joining us for day 2 of Onco Talks 1. After an insightful opening session yesterday, we are excited to continue our journey today with another evening of impactful discussions on oncology. To officially begin today's proceedings, may I now invite our convener, Dr. Ashish, to deliver the welcome note and set the tone for the evening.
Thank you, Halak. Good evening, everyone. I welcome you all on this day 2 of Onco Talks 1. Yesterday, we had wonderful discussions of many topics. And today, also, we have multiple uh, panel discussions and talks also lined up. So, without further ado, I would like to request Dr. Pralay Basu, who is a consultant medical oncologist in Nissan Hospitals, Kolkata, and he will be talking about systemic therapy in advanced biliary tract cancers. Dr. Pralay, please.
Thank you for the introduction. Can I just have the slides on the screen? Yes, I'm ready to start. Can you just?
Yes, Dr. Pralay, I think you can start.
Yeah. Okay. Can you just go to the next slide, please? Yeah. Good evening, everyone. I am Dr. Pralay Basu. I am a consultant medical oncologist at Nissan Hospital, Kolkata. Today, I'll give a brief discussion about the recent advances in systemic therapy in advanced biliary tract cancers. The majority of the discussion will be on advanced biliary tract cancers, and if time permits, in the end, I'll just touch upon a few points on advances in the adjuvant setting as well. Without further ado, I'll go to the topic of the discussion. The biliary tract cancers are a heterogeneous group of tumors. They may be broadly of two categories: the gallbladder carcinomas and the cholangiocarcinomas. The cholangiocarcinomas again being intrahepatic, perihilar, or distal cholangiocarcinoma. So the incidence of the biliary tract cancers is increasing more in the Southeastern Asia and South American continents. Because of the advanced stage of presentation, they have a very poor 5-year survival. The advanced stage of presentation is basically because of the lack of early symptoms, the vagueness of the symptoms and non-specific symptoms, as well as absence of any proper screening strategies. So next slide. Yeah. So again, the anatomical subtypes, there is not much detail to go into this. As I already mentioned, there are GBCA and cholangioCA. A cholangioCA may be intrahepatic, a perihilar, that is the Klatskin tumors, and the distal cholangiocarcinoma. Next slide. Yeah. What is the burden of the disease in India? According to the worldwide Globocan data, the gallbladder cancer ranks 22nd in the incidence and ranks 20th in the mortality. That is, there are 1.2 lakh new cases per year and 89,000 deaths due to GB cancer. Next slide. So this is basically showing the incidence in males worldwide. And as you can see, as I already mentioned, in the India, as well as in Southeast Asia, as well as in certain parts of South America, it is the hotspot areas shown in the dark blue coloring. So these show particularly high incidence of gallbladder cancer in males across all ages. Going to the next slide. You can see a similar trend in the females as well. So there is a particular hotspot in the Southeastern Asia, especially in the Indian subcontinent, as well as in some parts of Africa and a huge chunk of South American continent. Next slide. So in India, it is the 19th most common cancer, while it ranks 15th in cancer-related mortality. There are 20,000 new cases in a year and approximately 16,000 and deaths. And going to the next slide. So this is again the slide depicting the incidence and the mortality in a particular year as well as the prevalence. Going to the next slide. Risk factors for the biliary tract cancers are primary sclerosing cholangitis, cholelithiasis, chronic hepatitis, obesity, biliary tract infections, diabetes, smoking. One particular thing I would like to discuss is the high incidence of GBCA in the Gangetic belt, because being a practicing doctor in West Bengal, we see a high proportion of carcinoma of gallbladder and biliary tract cancers. This can be attributed to a number of factors. Most importantly, is the prevalence of gallstone disease, chronic infections, environmental pollution like contamination of water with arsenic, cadmium, certain diabetic factors, and certain geographical and genetic factors. Going to the next slide. Now coming to the basic crux of the discussion. And before I go into the systemic therapy, the majority of the systemic therapy, the recent advances is related to the immune checkpoint inhibitors. I should not proceed further without discussing the immunobiology. In the biliary tract cancers, there is an immunosuppressive tumor microenvironment. There is a dense stroma with desmoplastic components. Lack of effector T cells, there is an abundance of Tregs and myeloid derived suppressor cells. All of these features lead to a suppression of the anti-tumor immunity. TAMs in the biliary tract cancer, predominantly M2 like phenotype, also promote immune evasion, leading to a tumor progression. Next slide. PDL1 expression is quite variable. Tumor mutational burden is generally low. A small proportion show deficiency in MMR, that is the microsatellite instability high. And in case of intrahepatic cholangiocarcinomas, there is a higher degree of immune cell infiltration than the extrahepatic ones or the GBIC cancers. Next slide. Before I go to the recent advances, we need to take a look at the historical standard. For a number of years, based on the data from the ABC-02 trial published in the NEJM, and gemcitabine plus cisplatin was the standard of care for biliary tract cancer systemic therapy in advanced disease. Next slide. When and they compared gemcitabine single agent versus gemcitabine and cisplatin, they showed there was a improvement in the median survival, which was 11.7 months with the combination, while it was around 8 months in the pre-combination era. The ABC2 trial had a primary endpoint of overall survival. However, the trial had a few shortcomings, especially when we evaluate it in the era of modern medicines in oncology. There was an unmet need for durable responses. Going to the next slide. Here we see that there was a while the response was seen both in terms of PFS and overall survival, the lack of durable responses was quite less. However, it was for that era improvement in overall survival by 3 months, especially in a lethal malignancy in advanced stage like a gallbladder and biliary tract cancer. It was a highly significant finding. Next slide. Why do we go? Why did we go for immunotherapy? As I already discussed, the immunosuppressive microenvironment plays a role. So the rationale for ICIs in such a setting is that there is antigen release, priming of the APCs, T cell activation, which leads to tumor killing. Next slide. However, there may be a caveat for the ICI use, which is the variable expression of PDL1. Although in recent times, in various discussions and various evidences, we have seen that PDL1 itself is not a very reliable marker. Still, for the purpose of discussion, it has to be mentioned that the various trials using PDL1 inhibitors or immune checkpoint inhibitors, as in case of biliary tract cancer, showed that the positivity of PDL1 was highly variable, ranging from as low as 9% in some trials to 72% in some trials. So, next slide. So, firstly, they started off with monotherapy trials, like in a lot of cancers. So, PDL1 positive advanced BTCs and as well as PDL1 positive previously treated BTCs were treated with Pembro in two keynote trials. Both had small cohorts, had a less than reasonable overall response rate, and nivolumab was also tested, and they had showed a slightly better disease control rate of 37%. Next slide, please. So, again, the in the first line setting, there was a variability in the ORRs in the first line setting and the pre-treated setting, which is again quite expected. So, next slide. So again, there was an important subgroup in that, which I mentioned, that the DMMR MSIH population and comprises quite a small population, but in such cases, the response rates were quite significant. More than 40% response rates were seen in some cases. And we know that there are these days there are tumor agnostic approvals for like Pembro for MSIH, which are quite justified, taking into account the evidence seen in the single agent trials. Next slide, please. So then came the combination of chemotherapy and immunotherapy. The two most important evidences in this regard are the standard of care in the current generation. The practice defining trials were the Topaz 1, which was evaluated the role of combining durvalumab with combination chemotherapy, or the Keynote 966, which evaluated Pembro in combination with the standard of chemotherapy, that is GEMSIS. There was another trial which evaluated the role of nivolumab as well, which I will discuss, the BUILD-01 trial. Next slide, please. So, again, why the combination works, or why it was assumed it would work, and definitely the results also backed up this assumption, was that there is immunogenic cell death and neoantigen presentation, which leads to modification of tumor microenvironment, and there is enhanced T cell activity. Next slide, please. So, coming to the highlights of the uh, modern trials, the practice changing trials. The Keynote 966 included previously untreated, unresectable, locally advanced or metastatic biliary tract cancers. Pembro 200 mg or placebo was in combination with gemcitabine and cisplatin. 8 cycles maximum of chemo immuno combination, and then continuing maintenance Pembro in responsive or stable disease every 3 weeks till a maximum of 35 cycles. The primary endpoint and was overall survival, and this endpoint was met. The median OS was close to 13 months compared to 11 months, and with a slightly less desirable hazard ratio of 0.83. Next slide. So here we can see the survival curves. This is the OS data. So there was a small but statistically significant and difference improvement in overall survival, as you can see in the graph. Next slide, please. Next slide. Yeah. So the other practice-changing trial was the Topaz 1 trial. It also included a large number of patients with the more or less the same inclusion criteria, and it evaluated Durva in combination with GEMSIS, maximum 8 cycles of chemoimmunotherapy, and then there was maintenance, monotherapy maintenance till progression or unacceptable toxicity. It evaluated the OS as the primary endpoint and PFS as well as toxicity as the secondary endpoints. Next. So here again, the median survival was improved. Again, a slightly less desirable hazard ratio, but the 12-month OS rates was also improved. However, a significant finding for the survival curves in this trial was the separation of the Kaplan-Meier curves. So at the I have shown with the arrow in the curve that around the time of the 6 months, there was separation of the KM curves, and the separation persisted and with time increased. So, the separation of the survival curves in favor of the Durga group was seen, and which pointed to a uh, presence of durable responses with the use of immune checkpoint inhibitor in combination with chemotherapy. Next slide, please. This is again the card for the progression-free survival, and here also you can see that gradually there was a separation of the cards, and the separation was maintained for some time. Maintained for some time. So the Topaz one update came out recently in the sense of 1 year back. It was again the same trial. The updated overall survival data was presented. And going to the next slide, please. Next slide, please. Yeah. So here also the 24-month OS rates was markedly increased. The 24-month, that is the OS rates at 2 years was almost double. That is around 12% for the chemo only arm, while 23.6%, that is around 24% for the chemo immuno arm. So even though the median survival difference was not that much, hardly 2 months, but with a hazard ratio of 0.76, but there was a sustained benefit it with time, and there was no new safety issues. So it established, or rather it recommended, that the regimen be continued as a standard of care for first line in advanced biliary tract cancers. Next slide, please. So again, and this is something, a comparison which is usually not desirable, a cross trial comparison, but still for the sake of discussion, for Pembro versus Durva, the median survival in months for all three results, that is the original Topaz result, the updated Topaz result, and the keynote results, were more or less comparable. That is, it was close to 13 months in all cases, and the hazard ratios again were more or less in the same vicinity. So next. Again, as this is a depiction of the data, so you can see if it is grossly compared in terms of months of survival, the data might not reflect that huge a change to justify quite expensive treatment in case of lower middle income countries. But the advantage being that of a durable response, which is something which is very much required for such an aggressive and morbid disease. Going to the next slide, please. So as I mentioned, another trial was that of Nivo. It was only in a phase 2 setting, and it was a multi-institutional trial which compared Nivo chemotherapy combination on Nivo EP. The 6-month PFS was 59.4% for the Nivo chemo arm. Median PFS was around 6.5 months, and median OS was around 10.5 months, which is comparable to the overall historical data. But the 2 year OS rates was quite significantly high, that is 35.4% for Nivo with Gemsys. Next slide, please. So basically, the conclusion of this trial was that although it did not improve the 6-month PFS as compared to the historical standards, and median OS was also less than 12 months, but the high 2 year OS rate suggests a durable response and may be beneficial in a small cohort of patients. Next slide. So, biomarkers of response. These are concepts which can be applied irrespective of the sites of the disease. Biomarkers of response to immune checkpoint inhibitors are grossly PD-L1, TMB, MSI status, tumor microbiome, etc., etc. But the status in BTCs is that except the MSI status, none of them are very consistent predictors, because Firstly, the expression rates are either low or extremely variable, and their impact on the survival or outcomes has not been assessed to that extent because of such variability. Next slide. So again, the relative strength here, as I have said, that MSI is a strong predictor of response to immune checkpoint inhibitors that has become the basis of tumor agnostic therapy in these days. So that is something which does not need to be discussed in the setting of a single subsite because it is seen across most tumor subsites. So next slide. So, what are the new strategies? The new strategies which are being evaluated are combination of immune checkpoint inhibitors, combining an immune checkpoint inhibitor with an anti-VEGF agent, and combination of other TKIs with immune checkpoint inhibitor. So we have I have chosen three trials which I will briefly touch upon. One is the data of Lenva Pembro in previously treated BTCs. It is a biliary tract cohort in a multi-cohort phase 2 trial, the LEAP-5 study. For anti-VEGF and ICI combination again, and this we have chosen the IM Brave study, which is again a phase 2 data of atezo plus bevacizumab and in combination with chemotherapy for advanced biliary tract cancer, and also trial of toripalimab with lenvatinib and Gemox, which is a promising agent. So going to the next slide. So firstly, for refractory BTCs, there was a evaluation of Nivo and EP by Klein et al., which showed a ORR of 23% and a median OS of 5.7 months. It definitely holds promise in immune excluded tumors. As I mentioned, the IM Brave data, the phase 2 data in the first line of Atezo, Bev, Gem, and Platin versus Atezo, Gem, and Platin. Basically, the addition of bevacizumab to the triplet combination increase the PFS slightly, but the small sample size and a non-comparative design left a lot to be desired, and it really cannot be implemented in practice based on this data alone. Next slide. So toripalimab, Lenva, Gemox has a promising results. It is a single arm phase 2 study, but it showed an ORR of 80% and a median PFS of 10.2 months. Especially when we are seeing a median OS of 11 or 12 months, a median PFS in this setting of 10.2 months might hold definite promise in the future, but it needs to be validated in a phase 3 setting before it can be implemented in practice because this trial was a single arm phase 2 study. And the LEAP 5 BTC cohort evaluated Lenva Pembro in the second line. It was non-randomized, open label, and phase 2. Median PFS in the second line being 6.1 month and median OS of 8 months in the second line is again something which can be looked upon in the future. So next slide, please. Next, coming to some things which are definitely not there in practice at the moment. They are a long way away from being in practice, but again should be discussed being an academic discussion. That is the vaccines and cellular therapies. So clinical efficacy has not been established. Targets are WT1 and MUC1. They have shown safety and immunogenicity. The challenges are low neoantigen load and T cell exhaustion. Next slide. Novel agents, again, some are being evaluated. Ivonescimab plus chemo in the first line, and which is again a PD-1 and VEGF being the target. Median PFS is promising in the first line, 8.5 months. The Enlighten phase 2 trial of envafolimab with lenvatinib plus Gemcis in the first line showed a ORR of 45%. Again, something which should be evaluated in a phase 3 trial, and some newer checkpoints are being evaluated in early phase BTC cohorts. Next slide, please. So this being ivonescimab is a tetrameric
Dr.
bispecific.
Pralay, I would request you to please finish in 2 minutes your time.
Yeah, I'll be done in 2 minutes. I'll just finish. Okay. Yeah. So it is. These are both bispecific molecules. They act both have a synergistic anti-tumor and complementary effects and act through both the pathways. And envafolimab is especially useful because it is available as a subcut injection. Next slide, please. This is the last significant thing to be discussed. That is the histone deacetylase inhibitor, entinostat with nivo-IP. Again, it has a rationale because as it increases the CD8 effector FOXP3 ratio, and it is being evaluated and may have there is preliminary evidence of clinical efficiency. And next slide, please. Just let's go through. HER2 positive BTCs. These are again 10 to 15% Indian patients. Trial by Muddu et al. Retrospective study showed a median OS of 20 months when trastuzumab was combined with the immune checkpoint inhibitor and chemotherapy. Next slide. And the CLAR IDH5 trial showed the efficacy of ivosidenib for patients with advanced cholangiocarcinoma with IDH1 mutation. Next, please. And ardafertinib has been shown to demonstrate benefit in the phase 2 Ragnar study for patients with cholangiocarcinoma cohort having the mutation, FGFR alteration. Phase 2 data. Next. And real world data. Next slide, please. Next slide. Just destroy it. Next slide. Yeah. So median PFS was 8.2 months in our Indian data. Median OS was 12 months, consistent with the data from the Keynote and the Topaz trials. Next slide. Next slide, please. Again, it shows comparable data. So low dose ICI is something which is being explored, especially in low middle income countries, because feasibility in resource limited settings and it is the exploratory hypothesis generating study. Next slide. This is again the paper by Patel sir et al. Next slide. Next slide. Yeah, next slide, please. So this is the NCCN guidelines showing the recommendations in the first line and subsequent lines. Next slide. Yeah. So barriers in our settings are high drug cost, limited testing, and need for multidisciplinary immune-related adverse event management. Next slide. These are the future directions, using new adjuvant setting and personalized use of ICS. With that, I'll conclude. Thank you, and sorry for the going beyond my allotted slot.
Excellent talk, Dr. Pralay. So basically, I have two questions. So,
Yeah,
first,
sure.
you also pointed out that study by Mudo et al.
Yeah.
Mudo et al. That was a study from AIG.
Yes.
The median OS was 20 months, and it was for HER2 positive patient.
Yes.
You tell me, how emphasis do you give for HER2 testing in your BTC patients?
Basically, for heart-to testing in BTC patients, as even in the data by Muddu et al., it was seen in 10 to 15%, and of as per the reported data. And so, heart-to testing right now, I have not implemented to that much extent in my clinical practice. I have not been able to because already there is a cost burden and with the ICIs and chemotherapy combination and further testing, especially when it is not a standardized recommendation right now, I have not been able to implement that much in practice. However, with the especially with agnostic approvals for HER2 directed therapy, I will definitely consider that as a second line option.
So HER2 testing basically in gallbladder, they say it ranges from 15 to 30%, which is more
Yes.
than breast cancer. And that
Yes.
Montreal study, that study was only around 38 patients, if I'm not wrong.
Yes. Yes. Yes.
So
It
HER2
was.
testing is very important.
It
In
is very
that study, it was HER2 positive BTC. In the first line, they used
Yes.
pembro plus trastro plus chemotherapy.
Yes.
The median
Yes.
OS was 20
Was
months.
20 months. Yes.
So
Definitely
HER2
remarkable
testing
data.
is very underestimated in BTC.
Yes.
That is
Yes.
very important
It is
because I myself
definitely.
have two patients on Pertu and trastuzumab. They are doing good for 1 year.
Okay.
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 Number
Yes.
one. Number two, you talked about immunotherapy. In
Yes.
that keynote 158 study, the
Yes.
BTC subset in which pembrolizumab was used for MSI high patient, the median OS for those subset was also 24 months. And in
Yes.
first line IO trials, the maximum median OS which we can achieve is around 12 months.
Yes. Yes.
What do you think should be the ideal sequence? Pembro in the first or immuno in the first line or in the second line? Because if you give in the second line, we can get a better OS also, and we can also save a lot of money of patient as well. What's your take on that?
Yeah. See, basically, when for a MSI age tumor, of course, the results have been much better compared to the other variants, and MSI age is a strong predictor of response. So it is something which has to be balanced, because of course, being giving a good response, it can and prolong the survival in the first line. On the other hand, if we use the standard therapy in the first line and go to the ICI in the second line, the sequential added benefit of survival might actually be a bit more. So it is something which I would definitely consider. But MSIH, tumor agnostic therapy in first line, is something I would still prefer if I get a MSIH patient.
Okay. Thank you, Dr. Pralay, very much. So next we have Dr. Rahul Agarwal, who is a consultant surgical oncologist from Netaji Cancer Hospital. And over to you, Dr. Rahul.
Hello.
You're audible. You're audible, Dr. Rahul.
Okay, I'll just share my screen.
Yes.
Yeah, is my screen visible?
No, it's not, Dr. Rahul.
Just a sec. Hmm. Now is it
Yes, yes,
visible?
yes, yes, they are visible.
Okay, yeah. First of all, I would like to thank the organizers and especially Dr. Ashish for this kind invitation and allowing me to speak on this subject. Now, the topic that has been given to me is the role of axillary staging in early breast cancers. Is this an end of an era? Now, if we look at the question of why as to we are questioning the role of axillary staging in early breast cancers, the topic is not new. The natural history of axillary staging has gone a radical change from the era of Halsted, where a radical mastectomy and removal of all the levels of lymph nodes was questioned in some trials, followed by the role of sentinel, and then followed by the questioning of the role of sentinel lymph node biopsy itself for the after the advent of neoadjuvant chemotherapy. And in the subsequent slides, we'll see how the management of axilla has changed over the years. Now, let me first come to the first trial, NSCVP-04 trial, which would try to assess the role of radical mastectomy in the management of breast cancers. We all know that radical mastectomy has a great deal of morbidity, removing all the major limbs in the upper organs. This trial enrolled patients in 3 arms, comparing radical mastectomy with total mastectomy with radiation with total mastectomy alone. Now, in the patient who had negative lymph nodes, if I do a radical mastectomy or a total mastectomy alone without addressing the axilla, my disease-free and overall survival does not change. This became very thought-provoking in terms like and questioning the real role of ALND in management of breast cancers. Even in patients with positive nodes, a radical mastectomy or a total mastectomy with radiation did the same distant disease-free survival and overall survival. If we look at the subset of patients who had undergone radical mastectomy compared to total mastectomy, in patients with radical mastectomy, 40% of the patients had a positive node. But in the total mastectomy arm, only 19% of the patient failed, indicating that not all the positive node translate into a clinical manifestation. After the role of ALND was questioned, sentinel lymph node biopsy came into being, and it became a norm that patients only having a sentinel lymph node positive need a axillary lymph node dissection. But as we assess the biology of the tumor more, we came to know probably a patients having a low volume of disease in the axilla might not need a completion ALND. The landmark ACOSOC Z11 trial showed in patients with T1 and T2 and clinical N0 lymph nodes in the axilla who have up to 2 lymph node positive had similar overall survival and disease-free survival. In fact, patients having 2 lymph node positive, if I choose to observe, and if in patients who are doing ALND, the nodal recurrences might be slightly higher, but my overall survival and disease-free survival do not change. Next in line came the Amaros trial, which is axillary mapping, radiation or surgery. In this trial, tried to show that is 2 lymph node really the cutoff? In this trial, all the patients underwent sentinel lymph node biopsy, and irrespective of the number of lymph nodes involved, the patient was randomized to either axillary node dissection or radiation therapy. Again, this trial showed that there was no difference in terms of overall survival or disease-free survival, but the lymphedema rates were higher in the ALND arm as compared to the radiation arm. This gave an idea that probably an completion ALND is not required, and radiation, being a lesser morbid technique, probably can be used to manage the axilla. Now, after we are done with the question that axilla do not have any bearing on the overall survival and the disease-free survival, probably axilla has a role in local control. This question was answered by the study by Rees et al. From SEER database. They showed that in tumors less than 2 centimeter, the rates of positive axilla is less than 10%. Another study by Ugras et al., published in Annals of Surgical Oncology in 2014, they also showed that the incidence of lymph node metastasis in the axilla is also dependent upon the tumor subtype, where the HER2 negative, be it luminal A or triple negative subtypes, have both lower rates of lymphovascular invasion and lymph node positivity as compared to HER2 overexpressing tumors. Now, Lee et al. Studied a specific subset of patients where more than 3,000 postmenopausal women with T1 and T2 N0 lymph nodes were assessed, and how many of these patients had a heavy nodal burden. It was shown that barely 3.6% of the patients had the probability of having two or more or a heavy lymph node burden in the axilla. That means in the early stage breast cancers, the probability of having a high volume disease in the axilla is exceedingly low, less than 4%. Now came the question that okay, axillary omission may be safe in mastectomy. Is it really safe in the breast conservation surgery? Now, if I look at this trial, INT 080998 trial, where the patients are randomized to quadrantectomy compared to quadrantectomy with axillary lymph node dissection. Again, in this trial, they again showed that overall survival and disease-free survival was the same. In fact, on a subset analysis, it was seen that those patients who had a relapse in the axilla, they had an aggressive biology as compared to in the quadrantectomy arm, having no recurrences without management of the axilla had a favorable characteristics. Again, proving the concept that probably the lymph node failures in the axilla are more dependent upon the biology of the disease rather than the actual metastasis in the axilla. Now, again, coming to this landmark trial, CalGB 9343 trial. Now, this took the management of axilla one step further. Can we omit both ALND and radiation? In this patients, in this trial, having a robust follow-up of around 12.6 years, patients randomized to receiving more than 70 years were randomized to receiving tamoxifen with radiation or tamoxifen alone. Now, those patients had, again, with radiation arm, the local recurrences were lesser as compared to those receiving only tamoxifen. But all those recurrences in the axilla were salvageable, and hence the 10-year overall survival was the same between a tamoxifen with radiation arm as compared to tamoxifen alone. This study again showed that axilla, whether it's managed by radiation or is managed by ALND, or it's managed just by tamoxifen in again a subset of patients, does not compromise the survival. Even in case of recurrences, time to mastectomy, distant metastasis, breast cancer specific survival or overall survival does not change. Now, coming to the two landmark trials which have recently come into vogue and really has shaken the foundations of axillary management. The first one out of it is a sound trial. Now, the SION trial enrolled patients who had tumors less than 2 centimeters, any age, both pre and postmenopausal patients undergoing breast conservation surgery. These patients had a negative clinical examination of the axilla as well as no pathological nodes on the ultrasound of the axilla. Those patients having a suspicious single node of axillary lymph node underwent a FNAC, and the FNAC turned out to be negative. They were randomized to only SLNB and no further axillary surgery. The primary outcome of this study was distant disease-free survival. Now, if you look at the axillary recurrences in out of 708 patients who had undergone sentinel lymph node biopsy, barely 3 failed, and those who underwent no axillary surgery, even omitting the sentinel lymph node biopsy, only 5 failed. Numerically, the failure rates are very, very low. The primary endpoint of the survival of the study was distant disease-free survival. Again, between the two arms compared to SLNB versus no axillary surgery, the distant disease-free survival remained the same. Secondary endpoints, overall survival and disease-free survival, again showed that both are not compromised if we choose a subset of patients and choose to omit axillary staging. The conclusions of the sound trial now showed that this is absolutely safe to omit the axillary lymph node dissection and can be applied to a specific subset of patients. Coming to the INSEMA trial, which is more recently published. Now, it was a non-inferiority trial enrolling almost 5,000 patients with early breast cancer. A robust 4:1 randomization where out of 4 patients randomized to sentinel lymph node biopsy, 1 patient was allocated to no axillary surgery. In this trial, patients underwent breast conservation with whole breast radiation. One difference with sound trial where we had a distant disease-free survival, the primary endpoint of this study was invasive disease-free survival. The median age of the patients enrolled in this trial was about 62 years. 90% of the patients were T1 disease. 98.5% of the patients having hormone positive disease. 3.6% were HER2 positive. All the patients were node negative on ultrasound examination. Now, after a follow-up of 6.1 months, 5-year invasive disease-free survival was the same between no surgery and sentinel lymph node biopsy group. The hazard ratio for invasive disease survival was 0.91, meeting the non-inferiority criteria, and even the 5-year overall survival was almost similar between the two arms. But quite naturally, if you are not operating on the patients, the incidence of lymphedema and arm mobility was better in the no surgery arm. Now, so we have seen that axillary node dissection has no bearing whether in terms of overall survival, disease-free survival, or in terms of local control. But one question still remains that in few of the studies like Monarch study, which has shown that in CDK inhibitors do have a benefit reducing the local recurrences when it comes to early breast cancers who are hormone receptor positive and HER2 negative. So by omitting axillary lymph node staging, are we denying those patients those CD4 inhibitors, omega cyclin, which could have further reduced the rate of recurrences? Now, this is a very interesting data from Senomac trial. The primary purpose of Senomac trial was to again ascertain whether in patients with sentinel lymph node biopsy can we omit the axillary lymph node dissection. But on having a closer look of at this, I'm sorry. You can see my slides. Yeah,
Yes,
on
sir.
having a closer look on this study, what the investigators found that in order to prevent one recurrence, almost 104 completion ALND would need to be performed. After these, almost 9 patients will suffer a severe arm impairment or lymphedema. This highlights the fact that do we actually need to perform axillary lymph node dissection and give morbidity to so many patients just to prevent one recurrence? Now, the key takeaway from my talk is that we still need to ascertain what is the level of information do we need to individualize treatment of the patient. Secondly, we need more information to assess the oncological outcome and not compromise and to in fact reduce the morbidity of the patient. Now, in the era of genomics, biological and molecular characterization of the tumor, and there's an increasing role of liquid biopsies. Probably more data is still needed to ascertain before we can entirely remove axillary lymph node staging. Now, probably in the immediate future, axillary lymph node dissection will not be removed. But these recent trials are definitely data generating and evidence generating, and probably in near future we might see even a de-escalation of surgery in the axilla. One thing that still remains that we need data on the Indian patients. And lastly, we know that in luminal A subtype, a 20-year follow-up is needed because a lot of patients fail almost 5 to 10 years after the primary management. With this, I would like to end my talk, and thank you for patient hearing.
Excellent talk, Dr. Rahul, as always. So, any question? Dr. Chandrasekhar, Dr. Satish, Dr. Pralay. So, if I would ask you, since whatever trials you have shown, majority of the trials having majority of T1 patients, okay,
Correct.
T2 patients are very less, and
Correct.
also they have taken postmenopausal patients, earlier grade 1 to grade 2 patients, and
Mm-hmm.
mostly hormone positive patients. So, what
Correct.
is your takeaway? When I what's as a medical oncologist, what should we understand? What all the subset of patients in which we can avoid axillary dissection?
See, Dr. Ashish, the data what we have is very thought-provoking, and it's very strong regarding the elimination of axillary surgery. But these practice changing guidelines need more time, because the follow-up of the, I just say that like in sound trial it was just 6.1 years. So that short trial does not translate really into a clinical benefit, especially when CDK inhibitors have shown to have a lower incidence of recurrences. So as of now, completely eliminating axillary surgery, I think it's a still way around. But yes, in probably in patients above 70 years, small tumors, fragile patients, probably those sort of patients I would prefer to avoid axillary stitching.
So the conventional teaching
Yeah,
which we used to follow.
yeah,
Okay. Thank you, Dr. Rahul.
yeah. Thank you, sir.
So next we have Dr. Satish Sharma. He is consultant medical oncologist from Manipal, Ranchi. So he'll be talking about a role of immunotherapy in TNBC. Over to you, Dr. Satish.
Avni, can you share the slides?
Sure, sir. Just a second.
Yeah. So I hope my slides are visible to everyone.
Yes, yes, they are visible, Dr. Satish.
So let's discuss. We have seen use of pembrolizumab. Most of us are using pembrolizumab in triple negative breast cancer. As we all know, the pembrolizumab is out of reach of many Indian patients. So let's see, can a different molecule which has same activity can be used in a breast cancer patient, especially in the patients who are less affordable and where the pembro is out of their pocket. So next slide. So as we all know, there is TNBC accounts 15 to 20% of all breast cancer. Probably in eastern side, we have more than 20%. At least in Jharkhand, I can say it is around 30 to 40% of the patients who are triple negative breast cancer. And as we all know, because of their aggressive in nature, young, they are this patient, they are young at presentation, and it has got worse prognosis because of the limited treatment option. But having said that, TNBC also has a high TMB, which is associated, at least said, to have improved response with immunotherapy. And when we use with chemotherapy, concurrently with immunotherapy, they work synergistically to with a checkpoint blockade to improve immune activation. So we had in early phase one, toripalimab showed a anti-tumor activities in a patient with advanced TNBC as a single agent. Now, Torchlight is a phase 3 RCT which compared the efficacy and safety of toripalimab versus placebo in combination with nab-paclitaxel, which we generally use in our patients. Next slide. Now, it was a double blind phase 3 trial, RCT it was. So the clear eligibility criteria was it has to be histologically confirmed triple negative breast cancer. It should be stage 4 with less than one previous chemotherapy, or it should be locally advanced, not amenable to surgery. And the ECOG PS 0 to 1. Now, total of 531 patients were enrolled, out of which toripalimab arm received toripalimab plus nab-paclitaxel. 350 people, 353 people received tori plus nab-paclitaxel versus 178 people received placebo plus nab-paclitaxel. The stratification factor which were used were PDL1 positive, CPS less than 1, CPS 1 to 10, and CPS more than 10. Now, another second was previous any taxane patient has received or not, or current line of therapy, but whether it's the first line or second line of treatment. Now, the primary endpoint was the PFS was assessed in PD-L1 subgroup and in intention to treat population. Secondary endpoint was OS in PDL1 positive subgroup and intention to treat population. And one and secondarily OS, PFS and overall response rate. Next slide. Now, when we see the patient demographics, PDL1 group, whether Tori and Tori plus nab-paclitaxel versus placebo plus nab-paclitaxel. So what we have seen that generally the age group, as we know, the TNBC generally presents in young age group. More than 82% of the patients were less than 65 years of age. And same with placebo plus almost 80%, and more than 65 years of age population was 18% versus 20% in PDL1 group. And similarly goes to ITT, intention to treat population. It was 81.9 versus 81 in placebo plus nab-paclitaxel group. Now, most of the people, their ECOG PS, as we, most of the patient who comes, generally they are PS1. So most of the patients are almost, so zero, 45% of the patients were ECOG PS 0, whereas 55 were in PS1. PDL1 status, as the stratification factor was there, CPS less than 1 was 0. So no person with CPS less than 0 was recruited in this subgroup. CPS less than 10 were 54 and CPS more than 10 were 46 versus in placebo group 62 and 38 respectively. So we had 80%, 84% of the patient which didn't receive any paclitaxel, and for more than 90% of the patient, almost 93% of the patient, or they were the first line who were chosen for nab-paclitaxel versus toripalimab. Next slide. Now, if we see the primary endpoint, which was PFS in PDL1 subgroup, we see that in tori plus chemo arm, there was a almost 35% reduction in the risk of progression of death. And at 1 year, it was 41.9% in tori plus paclitaxel arm versus 24.4% in only placebo plus nab-paclitaxel arm. At 2 year, we have seen that a BFS rate is 23.5% in tori plus nab-paclitaxel versus 14.5 in nab-paclitaxel arm. Next slide. Now, when we see the very interesting subgroup analysis, so we overall there was a response, there was a benefit with hazard ratio of 0.65%. Now coming to the age group, so surprisingly, the people who were more than 65 years of age, they didn't receive any benefit of using toripalimab. Again, another patient who has previously received paclitaxel, they received the response of HR was better than people who have not received paclitaxel. Similarly, patient who received who had de novo stage versus recurrent metastatic, in both the arms, there was a response. Now coming to the CPS score. Now what they told, more than CPS more than 10, there was a response also in a patient who has CPS less than 1. But we have seen that there were hardly any patient, they didn't take any patient in CPS less than 1. Next slide. So the another subgroup was PDL1. So whether it was beneficial in patient who had lung mets, bone mets, or liver metastasis, so it was equally effective in all the common metastatic site of triple negative breast cancer. And it didn't depend whether the patient has received neoadjuvant or adjuvant therapy for TNBC. Both were equally this thing, and it was also not getting affected whether the patient had previous radiation for TNBC or not. Next slide. Now, if we see the primary endpoint PFS in intention to treat population, so almost 8.4 months versus 6.9 months, almost 23% reduction in the risk of progression of disease in intention to treat population. So next slide. Now, if we see the results, the subgroup analysis, the another was OS treatment effects. So overall, there was a improvement in overall survival. But again, as we have seen previously also, the subgroup like age more than 65, there was no effect. Again, the patient who have taken previous paclitaxel treatment, there was placebo was doing better. And patient, again, in which it was used in second line, almost it's touching the line. So again, in best used nab-paclitaxel story in first line rather than using in second line. Next slide. So again, we see the OS subgroup analysis. So it was equally effective in patient with lung, bone, and liver metastasis, and whether previous surgery was done or not, whether previous radiation. So it was equally effective. Next slide. So when we know that initially the patient was stratified according to the CPS score. So CPS less than 1, the PDL population, there was the margin of response was low, 33.1 months versus 27.9 months. In CPS more than 10, the hazard ratio you can see it is almost 5.55. So what it was 18.3 months versus median OS was not achieved. And in CPS, we definitely expect a mixed response. Next slide. So if we see the response rate, so almost 66% of the patient had a good response rate, and almost 66% of the patient had either complete or partial responses. And median duration of response was 10.8 months. So the hazard ratio was 0.55 versus in intention to treat population, it was 0.64. Next slide. So otherwise, if we see a placebo versus tori, placebo plus chemotherapy versus tori plus chemotherapy. So no major side effects were reported, and the generally infusion related reaction or immune related side effect which we have commonly seen where the newer there were no new side effects. There were the common side effect which we have seen with immunotherapy. The same side effects were reported. Next slide. So when we conclude, we see that in phase 3 torchlight trial edition, the tori plus nab-paclitaxel has improved PFS. Although it has improved PFS by 2.8 months, the OS shows a positive response. So trial met its primary endpoint and interim analysis. So and the side effects profile, of course, we didn't find any new safety signals. And tori, we have been using Pembro. We have not seen any newer side effects with toripalimab. So again, the final OS, we'll have to wait for the final OS. So I think it is a good choice for a patient who are recurrent or locally advanced, where we cannot use pembrolizumab, or it is the cost burden is there to the patient. There we can use where the CPS, of course, the CPS has to be more than 1. Best if the CPS is more than 10. Next slide. So I think this was the last slide.
Excellent talk, Dr. Satish. So we know that with Pembro in advanced metastatic TNBC, the CPS cutoff which usually we take is 10. And in Torchlight, we see even patient with CPS more than 1 was getting benefited. The median OS for CPS more than 1 in Keynote 355 was not reached. So do you think this will change the way we treat CFS? Because we have seen the same thing with toripalimab in esophageal squamous cell carcinoma also. Because nivolumab used to be effective for CPS more than 10, but now more than 1 also. But now, irrespective of CPS, toripalimab is working in esophageal squamous cell carcinoma. So what's your comment regarding TNBC?
So I think it mainly based on the trial they design. So initially now CPS more than 10 you'll use in G junction, you'll use Pembro. But will you not treat the patient with immunotherapy who has CPS more than 5? Of course, we have nivolumab. We have CPS 1 to 5. We can use nivolumab. So tomorrow, if I get a patient of CPS 2 in a breast cancer, definitely if Pembro data doesn't save me in a court of law, I'll go with toripalimab.
Very well pointed out, because it's the trial design which is very important. We also saw that CPS less than 1 was not included in the patient. So maybe this patient selection is definitely very important. So thank you once again, Dr. Satish. Next, we have Dr. Rajan Yadav. He is Associate Professor in the Department of Medical Oncology, Gujarat Cancer Research Institute. And sir will be talking about neoadjuvant and adjuvant therapy in bladder cancer. Over to you, sir.
Can you see my slides?
Yes, sir.
Thank you. Thank you so much, Ashish, for this wonderful opportunity. I'll be talking about NSCT and adjuvant therapy in bladder cancer. Just a moment. Yes. So, increase in ICOS expressing T cells post CTLA blockade. This is inducible T cell co-stimulator ICOS expressing T cell cytotoxic T lymphocyte associating protein. This is a graph which shows how the clinicians look at it. I promise you, this is the last boring slide. I'll show it to you. So there are 3 types of movies in which first is a non-linear plot. So I'll proceed that way. There's the classical murder mystery in which no one knows what's happened. The Knives Out, the neo-noir, in which everyone knows what's happening. And the third one, in which everyone knows what's happened and they're just trying to prove how it happened. So I'm a big fan of Suspect X. So this is how I'll move. I will give you the guidelines first, and then we'll see how we go from here. So cisplatin eligible MIBC should receive NSCT. Preferred regimes are GC or DD-MVAC. I'm not a big fan of DD-MVAC. It's very difficult to give. And NSCT is not recommended for cisplatin ineligible patients. Really. So this is the bladder cancer prevalence in India. The bladder cancer burden, 25% of bladder cancers present with muscle invasive bladder cancer. There's a high risk of recurrence, and there is a definite role of systemic therapy, both neoadjuvant and adjuvant, to shrink the tumors, and they improve overall survival as well as PFS. The history is pretty simple. 1970s, cisplatin was there, and even after 55 years, it's serving us well. In 1980s, MVAC came, and then now in 2021's immunotherapy is talk of the town. So in stage 2, we use neoadjuvant cisplatin-based combination therapy, followed by cystectomy alone. There is an option of bladder preservation, and RT or TURP if not a candidate for cystectomy. The current treatment landscape for non-muscle invasive is intravesical BCG or a pembrolizumab. In muscle invasive, it's a neoadjuvant chemotherapy, gemcitabine cisplatin or gemcitabine carboplatin plus durvalumab based on the Niagara trial. Adjuvant Nivo and Pembro, there are pending approvals. And this is one of the few sites in which addition of NSCT has given a OS survival. So this is something which I won't waste much time on. I've discussed most of it. But the problem with chemotherapy is something like playing with matches. If you play with matches, you get burnt. It's toxic. So shorter duration of treatment, faster completion, reduced cytotoxicity, routine G-CSF support, and optimized pharmacokinetics. This is why the dose-dense chemotherapy was less toxic than the conventional one. Potential attributes of neoadjuvant therapy are you give TURBT, systemic therapy, and surgery, and there's a good local control, curable disease. Why chemotherapy neoadjuvant for MIBC? is something which Professor Barnett from MD Anderson worked on. The first trial was SWOG 8710, in which he proved that addition of any chemotherapy improves survival by decreasing the downstaging rates. His trial was 8710, republished with the new data and follow-up in 2003. It showed a 5-year benefit of the order of 14%. Meta-analysis published in Lancet 2000 showed a 5-year absolute OS survival and a 9% DFS. So current guidelines are cisplatin eligible patients should receive NACT. Preferred regimes are GC or dose-dense MVAC. Dose-dense MVAC has a paradoxically low toxicity rates, as I've already discussed. And NACT is not really recommended for cisplatin ineligible patients yet, but there are trials in progress which are bringing them there. Who should receive NACT? Ideal candidates are T2, T4A, N0, N1 disease, a good creatinine clearance, and cisplatin ineligible, as of today's thinking, should not receive. These are the people who changed medical oncology forever. Professor Allison and Sako Honyo. Allison's team at University of California, Berkeley demonstrated by blocking CTLA4 with antibodies led to enhanced T cell activation and laid the foundation of modern immunotherapy. In 2020, 2006, and 2012, few drugs were discovered which changed the course of solid tumor oncology. They got a Nobel Prize for their efforts. Now, the thing is, the question which we already always ask ourselves was that has immunotherapy brought a paradigm shift, or is it much ado about nothing? So there are few trials. PURE-01 is pembrolizumab. NABACO is a dual immuno-oncology trial, nivolumab plus ipilimumab, and ABACUS is atezolizumab. They showed wonderful PCR rates. But do the PCR rates convert actually into improved outcomes? So the PURE-01 trial showed that neoadjuvant pembrolizumab, there was a strong pathological response, better than the other ones, and helped the surgeon's selection for a surgery and better bladder sparing approaches. Nabucco trial had a similar dual checkpoint inhibition, had high efficacy, but required careful patient selection due to high immune related toxicity. The pathological CR was of the order of 46%. Abacus trial, they used atezolizumab, and PCR rate was not as good, but still stellar. It's a promising option in cisplatin ineligible patients demonstrating immune mediated anti-tumor effects. So you give either, go for cystectomy, and as we know, PCR rates were good, and PCR rates then translated into better outcomes. But the greatest trick that devil ever pulled was convincing the world it didn't exist. The devil here is bladder cancer, and it keeps coming back. So is PCR a good potential individual level surrogate marker? They showed that by having a good PCR, you could have a better long-term outcome. So in my understanding, as per the results of Abacus trial, a good PCR is and can be used as a good surrogate marker for a better probability of survival. So there are several ongoing trials with new adjuvant immunotherapy. Energize is there, Niagara is there, Keynote 866 is there, Keynote B15 is there, where they're using even better and complex drugs, the results of which will tell us what are going. So Niagara trial is Durva plus new adjuvant chemotherapy in patients with operable bladder cancer. The intention to treat analysis showed a better outcome with a hazard ratio of 6.68 and a very, very well significant result. Similarly, Keynote 905 was done where pembrolizumab was used, and the primary endpoint was PCR and EFS stratified by PDL1 greater than 10% and ITT. There are early phases of new adjuvant doublet therapies like Durva and Tremi, the NCT trial, and the Nabucco, ipilimumab and nivolumab, followed by cystectomy. All of them are showing good results, but I would rather wait and see those numbers translate into guidelines and get baked. These are complex things to give. Ipilimumab day 1, day 22, day 43, nivolumab. The regime is like they start with EP, then on day 22, they give a doublet. On day 43, they give Nivo. And day 63 to 67, they go ahead with the cystectomy. The PCR rates were stellar, 44%. And as we have seen in the Abacus trial, PCR rates translate into better outcomes. So greed, for a lack of better word, is good. कुछ तो शहर दे लोग सालिम सन कुछ सानू भी मरन दा शौक सी. So that means the disease is bad, but the doctors are courageous. So, can we identify patients with MIBC who can be treated curatively without cystectomy? Now, this is being very brave. You give nivolumab and then don't do anything. So, I think in this trial, 76% patients enrolled. There was a 43% CR and 70% remained disease free at a 30-month follow up. The CCR had a positive predictive value of 0.97, which is stellar. Bladder preservation is a feasible option with this regime. So जख्म दिखते तो हैं तब तो कोई दवा काम करे. जो छुप जाए अंदर उनका क्या करेंगे? तो जो छुप जाए अंदर का उनके लिए adjuvant chemotherapy देंगे. As Dr. Daniel Hayes says, adjuvant chemotherapy is a leap of faith, trusting data, statistics, biology over what is visible over imaging. It's not about the tumor that was removed. It's about the cells left behind. Again, these are the people who worked hard. And if you were missing, one of them was not Dr. Sidney Farber, it was Derek O'Brien. So please pay attention. So Donald Skinner and Michael Stockel are the doyens of adjuvant chemotherapy. Who needs adjuvant therapy? PT3, PT4, any N plus disease, or patients who didn't receive NACT. So there are multiple options. In good old days, it was GC or MVAC, and now it is nivolumab as well. So Checkmate 274 trial, nivolumab showed a disease-free survival of 21 months over placebo, but I would want it to be compared with the good old chemo. The takeaway is nivolumab is the new adjuvant standard for high-risk post-cystectomy patients. There is much weaker data for adjuvant, however, as compared to NACT. No RCT has yet proved a survival benefit. However, improved DFS is there. And if the patient is node positive, the greater the DS benefits. Adjuvant therapy for MIBC following cystectomy, we used placebo and versus nivolumab, and the results are not that encouraging, but it has somehow managed to become the new standard of care. So we had approval in August 2019, but it's like something which depends on patients' preference, priorities, tolerance to toxicity, and goals for treatment, and obviously in Indian setting, cost to patients and payers. Ambassador trial is adjuvant pembro versus observation in MIUC, and it also showed similar outcomes. Adjuvant treatment of MIBC following cystectomy in stage 2 or 3A, we use adjuvant cisplatin-based chemotherapy if no previous platinum-based therapy was used, and adjuvant nivo has now come into vogue. In high-risk therapies, there's that Checkmate 274 trial, which has established nivolumab, and the graphs are as far apart as possible. The hazard ratio, however, is not very convincing. There is a safety issue as well as with all the drugs. Even atezolizumab didn't show much of benefit. However, it's like you can give it if the patient has no observations. Coming to the Alliance and the Ambassador trials, these were randomized phase 3 trials of adjuvant study of pembrolizumab in muscle invasive and locally advanced urothelial carcinoma. It was pembrolizumab versus observation, and a man's got to know his limitations. So we got to know our limitations, that we work in a setup where not everyone understands the nuances of immunotherapy and not everyone can afford it. So coming to summary of adjuvant treatment in muscle invasive breast cancer, adjuvant immunotherapy has increased the DFS. We are now touching 11.5 months, but I'm not still sure overall survival. The pembrolizumab has also, Ambassador trial, increased the DFS by 7.2 months. Patient selection, like always, everywhere is important. And in research, as in life, we recross our paths, each discovery echoing into future Hope Ashish gives me another opportunity and very gives that very soon. Till we meet again, hasta la vista.
Thank you, sir. Excellent talk as always. So basically, I have one comment and one question for you. So basically, you just discussed the fact that in cisplatin ineligible patient, we don't have new adjuvant. Recently, a few days back only,
Yes, yes, yes.
EV303
That's why I mentioned yet in reds after all that.
with an amazing path CR of 57%. We never
Yes,
know.
yes, yes, yes.
We
Yes,
never
yes,
had
yes.
idea that
Yes,
even in
yes, yes.
cisplatin ineligible patient will be having that data. And
Yes.
don't you think this control arm, that chemo placebo arm in Viagra, sorry, Niagara trial, uh, basically did not include nivolumab in those patients who did
It
not
should
achieve
have.
PATH-CR.
It should have included. It
Number
should have
one.
included.
And also those patients who achieve PATH-CR, they rarely recur. We all know
They
that.
rarely
That
recur.
is the case in
PATH-CR
bladder
is a good
cancer.
surrogate marker. PATH-CR
Don't
is a
you
good
think
surrogate marker.
giving perioperative treatment is an over treatment?
Perioperative is a overkill in my understanding, especially in bladder cancer.
Okay. Thank you.
Thank you.
Thank you
Thank you
once
so
again.
much.
So we have two sponsored panel discussions. What do you team?
Thank you so much, Doctor, for giving us this opportunity. It was a very informative session. Now, I would like to invite Dr. Vivek Agrawal, Director of Medical and Hemato-Oncology, Narayan Super Specialty Hospital, Havra, who will be moderating this session. I would also like to invite his panelists.
Jhalak, sorry to disturb. Vivek sir is just joining in another 2 minutes. Can we just wait?
Okay. Okay, sure.
Yeah,
Good evening, sir.
yeah,
Welcome to the session. So, you will be moderating the session. I would also like to invite your panelist for this session, Dr. Sushant Hegde, Consultant Medical Oncology, Manipal Hospitals, Bhubaneswar, Odisha. Dr. Debapriya Mondal, Consultant Medical Oncologist, Apollo Multispecialty Hospital, Kolkata. Dr. Kaustuv Majumdar, Assistant Professor, Radiation Oncology, Chitranjan National Cancer Institute, Kolkata. Dr. Anuj Gupta, Associate Professor, Medical Oncology, Mahatma Pandit Madan Mohan Cancer Hospital, Varanasi.
yeah. Just let me share the slides.
Sure, sir.
Yeah. I hope everyone is able to see the slides.
Yes, sir, it's visible.
Just a second. Yeah, you all can see the slides now, and I hope I'm well visible and everybody can hear me well and the slides are moving. So we'll start ahead with this panel discussion on first line treatment of HR positive, HER2 negative metastatic breast cancers. Dr. Sushant, I can see. Dr. Anuj, are you there, sir?
Yes, yes,
Yeah, Dr.
I'm
Anuj is
listening.
there. Dr. Debopriyo is there. Dr.
Yes,
Debopriyo?
yes, I'm here.
Yeah, and Dr.
Yes,
Kaustav
yes.
Majumdar. Kaustav, are you there?
Yeah, I'm here.
Yeah, I think Kaustav, your voice is not very clearly heard.
Am I audible now?
I think the voice is still very low. Yeah.
Just a second.
Okay. So let us start with Devopriyo. So Devopriyo, whenever you encounter a patient of HR positive, HER2 negative metastatic breast cancer, so what are the factors that help you decide that what treatment you should go ahead with? What are the baseline evaluation that you ensure that that is a must? Anything specific that you want to sort of say beyond the baseline scans and the baseline investigations and all?
Generally, crisis is the first thing I look at whether the patient has visceral crisis. And if the
Visceral
patient
crisis.
is not in
Okay, very
visceral
good.
crisis, then I at least look at whether the disease is there is heavy disease burden, visceral burden, bone marrow metastasis as compared to say only bone only metastasis. So the clinical burden of the disease gives us some idea about the aggressiveness. And in some patients who are elderly, I also look at whether I'm in a comprehensive assessment, sort of a geriatric assessment, not in a formal way, but a fast in clinic way, how fit they are, and what has been their last treatment. That is something which is very important in hormone receptor positive, HER2 negative MBC. The
Correct.
duration from last treatment
Yeah.
and
So
if
I
they
think
had been on adjuvant.
So I think Dr. Devapriya clearly, sort of mentioned the most important things that, how aggressive the disease is, what is the disease burden, whether visceral crisis is there, whether visceral metastasis is there. Again, what is the patient symptom burden, what is the age, what is the tolerability of the patient, and how aggressive treatment whether the patient may be able to tolerate, and what is the endocrine resistance pattern that patient has, whether it's endocrine sensitive patient or patient has some sort of a secondary or a primary endocrine resistance, whether he was or she was on some sort of an endocrine treatment or not, or what are the treatment that the patient has taken before. Dr. Anuj, what about NGS and molecular markers? So in first line, is this relevant to you, or you don't look at any sort of first line molecular markers?
No, I think now it is becoming very important to look at the NGS at the baseline only because not only it helps us to predict the result what we are expecting because now as we are doing NGS in almost all the patients who are affording at and try to do it baseline, we are seeing that quite a good percentage of patients is having 63 CA mutation. And in fact, two of the patients who are treatment naive for any sort of endocrine therapy had even in their report ESR1 mutation was also present. So those patients, although since they were treatment names, we have started on the hormone therapy along with CDK4/6 inhibitor, but with the keeping that in mind and explaining the patient that although it is unusual, but that has happened, and we all know that if the patient is having 63 mutation again, then it is it is a
The
harbinger that
prognosis,
the patient
the outcomes are less.
may not
Correct,
the
correct.
results may not be that much good as
Yeah.
the patient who are non-mutated. So
Yeah.
that becomes
I
very
think Dr.
important
Anuj, I think
to
made a
focus
very
on.
a good point that rarely 3-4% patients treatment naive, not on any endocrine therapy, may have upfront ESR1 mutation, and in such patients, probably if you have option of using an oral SERD upfront, you will go ahead with it, or at least you will start with fulvestrant and not you will start with a aromatase inhibitor, correct? And
Yes.
if the patient has PIK3CA inhibitor upfront, yes, theoretically, and there is now option of using upfront newer newer PIK3CA inhibitors along with CDK4/6 inhibitors. That option is there now, but still with the available treatment options in our country, we still have to go ahead with the upfront CDK4/6 inhibitors only. But yes, the prognosis definitely is different, and we expect earlier progression, and then our monitoring may be different in treating such patients. Dr. Sushant, what about visceral crisis? Now in the current era, in the visceral crisis, how do you approach your patients? You still want to start these patients on chemotherapy, or you want to still treat with CDK4/6 inhibitors and a hormonal treatment?
If the patient is HR positive and with visceral crisis, then my preferred choice, even if whatever be visceral crisis, the preferred choice is CDK4/6 inhibitor. But there is something of selection of the CDK4/6 inhibitor that we saw if lung meds or anything other bone meds that can be well taken by the or the liver meds without any liver dysfunction, then we can use ribociclib is very much fair, even if patient is very much PS is 3-4 or because in that case also anyhow we are not able to give chemotherapy because PS
Yeah,
3-4
yeah.
it is not
I think we
from the literature. The practical experience I have treated with PS3-4 patient with ribociclib. My patient has improved. Still they are in on the ribociclib. Many patients 3 to 4 years. But one thing is about ribociclib. I want to comment that is that if the patient having the liver dysfunction, we are not able to give ribociclib. If patient have liver dysfunction, that is transaminitis or bilirubin is very high, then in that case we can use abemaciclib. So anyhow,
okay,
we have to
okay.
use CDK4/6 inhibitor.
Okay, so well accepted. I think what Dr. Sushant wants to make a point is that if liver dysfunction is there and you are giving ribociclib, you need to be really cautious, because we all have faced some patients, who go into liver failure, so you have to be a bit cautious when you are using ribociclib in such patients. Correct. Dr. Kostav, what about the menopausal status, and does your choice of treatment differ if a patient is premenopausal or a patient is postmenopausal? How do you approach the patients? And what about the endocrine partner?
Yeah, so if the patient is premenopausal, am I audible now?
Yeah, yeah, you're well audible now.
So, if the patient is premenopausal, so along with any ET, any endocrine therapy, I should consider first in their ovarian suppression. So, ovarian suppression by any means, it should be considered whether it is a surgical or a medical. So, medical should be preferable for any metastatic patient. And so the premenopausal, we should consider the ovarian suppression. And for postmenopausal, we don't need that. And regarding the CDK4/6 inhibitor, if we can see the, the Ribana data or complement data, whatever. So the ribociclib acts really well in the all setup. So
Correct.
there is no specific, but if you can consider for the waist benefit, might consider whether it is a pre or post, I would consider the ribociclib in that setting. Only thing is that in premenopause, I should consider for the ovarian suppression.
Okay, but would you ever combine tamoxifen with ribociclib?
Really not.
Yes.
There is no data till now. So
Correct, correct.
normally
So I think,
premenopausal is also, yeah.
Yeah. So I think Dr. Kostov clearly made this point that in premenopausal patients, we should always refrain from using tamoxifen as a partner with ribociclib. And it has been shown that this combination has really very, very high incidence of QTC prolongation. And that is the reason why, in most trials, tamoxifen was not used as an endocrine partner with ribociclib, and you would want to give ovarian function suppression and use an aromatase inhibitor, or you may use fulvestrant, but never use tamoxifen with ribociclib. Okay, so this is the treatment paradigm, and I think what has changed really is that the role of chemotherapy now really comes in only in cases which are post CDK4/6 inhibition and having imminent organ failure, or we are out of choices. And upfront nowadays we are much comfortable in using CDK4/6 inhibitors upfront in our patients, especially if they have visceral crisis, especially if they can afford a strong CDK4/6 inhibitors just like a ribociclib. Now, yes, this is also very important, that OS data. So I'll come back to Devopriya. So Devopriya, what is the one of the important goals when you are treating such patients? Is PFS a good enough goal, or you accept that PFS is a good surrogate, or you go by the OS data only, or you look at the quality of life and the response rates? What is your aim and a deciding factor when you look at the data of all the CDK4/6 inhibitors?
So all of them are very important endpoints and clinically relevant parameters that we have to look at in our clinic. EFS is important because we generally don't expect our later line treatments to work equally good or better. And quality of life is
But
very,
if you
very
have to
important.
choose like one factor which will decide your
Then obviously,
treatment,
in this sort of a disease where we are thinking in terms of more than 5 years, OS takes the
OS,
precedence.
yes. Dr. Kostov, one word answer if you have to choose: PFS, OS, response rate, quality of life.
I choose first OS and then
OS,
quality of
OS.
life.
Dr. Anuj, what is your take?
Yeah, definitely OS is the
OS.
priority.
So I
If,
think Dr.
if,
Sushant will not have the courage to sort of be different if all the three have already said OS, and we already know that ribociclib is the most unique one amongst all the three CDK4/6 inhibitors. There have been a lot of debate and a lot of reasoning as to why one molecule did not show OS, and the other showed the OS. But overall, across different trials, we have seen that ribociclib is the molecule that has shown a significant OS benefit in amongst all the CDK4/6 inhibitors when it has used in the first line, and that is one of the important reasons why ribociclib has been one of the most important and one of the most favored choices of a first line treatment. uh, you know Definitely quality of life is important. Looking at the safety profile is important. Looking at the response rates is important. And PFS, we all know, has its own shortcomings. The PFS data of ribociclib, palbociclib, abemaciclib all are equal. And if you are going by PFS, you hardly have a choice as to why you may choose one over the other. But when you look at the OS data and you look at the efficacy analysis and different real world analysis, definitely each one of us will conclude that yes, ribociclib has definitely shown OS data. It has shown that it is a stronger CDK4/6 inhibitor. It inhibits CDK4 more than the CDK4 CDK6, and that is the reason why it has more on target effects, lesser off target effects, lesser off target side effects like abemaciclib, because the abemaciclib has more CDK6 inhibition also as compared to CDK4, and has shown off-target side effects like the GI side effects and diarrhea, which is much lesser with the ribociclib. And the free drug that is there with ribociclib is much higher as compared to the other ones. Steady state concentration is maintained, and this is something which is reflected in the guidelines why NCCN considers category 1 to ribociclib in the first line. ESMO MCBS gives is at the highest score of 5 amongst all, and even the ABC guidelines also have shown that ribociclib is one of the most choices with the most highest consensus. Now, amongst the side effects and the quality of life, So, what are the challenges that we face, Dr. Anuj? What about the challenges and the side effects that you face when you're treating your patients with CDK4/6 inhibitors? Across different CDK4/6 inhibitors, and why you want to choose one CDK4/6 above the other?
So when data was not there, I'm talking about in 2018-19, when all the drugs were available, but we didn't have the mature OS data. Then side effect profile was one of the important parameter to decide which molecule we are using. So we know that abemaciclib is having a GI toxicity and a diarrhea, although it is only in Indian patient, but we have experienced that it is not a problem in Indian patient, although in Western data it is a common side effect. Similarly, is the case with the QTC prolongation, because we have also we have been treating a lot many patients, and even the patients who are having elderly patients or with the precautions we have started, and we have not seen any QTC prolongation which required dose interruption or discontinuation permanently. At times, we have to hold the drug because there is QTC prolongation in the range when we say we have to keep a check and repeat the ECG. But again, it is not a alarming or a red flag sign that we don't use, or we have lost any patient due to arrhythmia. That is the thing. With the palbociclib, we know that cytopenias and at times itching and certain skin reactions we have also seen. But again, now we are mostly treating our patient with diagnostic, and when the patient is not having some contraindication to ribociclib, then we go with the abemaciclib. And so palbociclib is third in the list.
Correct. So I think Dr. Anuj has summarized it very quickly and very nicely, and we all would agree that abemaciclib is not an easy molecule to handle. There are different grades of diarrhea and rashes that we see with our patients when we look at abemaciclib, and these GI side effects, these rashes and skin problems may be not easy to tolerate. So far as ribociclib is concerned, I think Sushant already mentioned raised AST, ALT, and a mild liver dysfunction is something that we are most concerned about. And if we do not have a really baseline deranged LFTs, ribociclib is such a safe molecule, because apart from QT prolongation and raised AST, ALT, really don't have much problems. And yes, neutropenia is something that is there, that is more with ribociclib and palbociclib, but they are hardly clinically relevant because you hardly see your patients going into any sort of neutropenic sepsis. Dr. Sushant, your experience with neutropenia with the ribociclib, do you think that it is relevant, clinically relevant?
Frankly speaking, I am not aware about any neutropenia if it is more than 2000 years. So because we know it is not a stem cell that like chemotherapy drugs. So I am not bothered with that. So my patient, if it is more than 2000 TLC, I advise them to continue the dose. And you mentioned the QTC prolongation. I am doing because of literature written that, because otherwise I am not seen any patient who has cardiac toxicity due to ribociclib. And you may also experience same as that.
Correct. Yeah, the issue is that we are never so vigilant in our practice and monitoring, and drug interactions are something that we hardly see, because many of our patients have polypharmacy, and they do take multiple drugs, which sometimes may cause QT prolongation. But the literature does say that the QT prolongation incidence may be up to 10% that you may see with ribociclib. But personally speaking, I hardly cannot remember a single patient where I have reduced the dose or stopped my ribociclib because of QT prolongation. So I totally agree that probably in Indian patients, what Dr. Anuj said, that QT prolongation may not be that important an issue, especially if you are already taking care of your drug interactions and not really using drugs which are simultaneously causing QT prolongation. So the quality of life data is also there, and that also favors ribociclib, and you can clearly see that here the neutropenia, again, this is something that we have already discussed, that it is hardly relevant, and you really don't care. So elderly population. So Dr. Costa, what about the elderly population? Now let us take a patient of 76-year-old who has presented with HR positive, HER2 negative advanced breast cancer, and has been treated with endocrine therapy for the past 5 years on adjuvant intent. Currently has presented with invasive disease to multiple vertebra, and has hypertension, diabetes. There is no evidence of organ damage. A PS1 patient. So how would you approach such a patient?
So if it is a 5 years already on endocrine therapy and progress, I would consider for a repeat biopsy from any of the lesion.
Correct.
And we consider for the ERPR.
So it is
HER2
ERPR
status.
positive, HER2 negative.
Yeah. So, so if it is a kind of a primary resistance is there, okay. So might
So
be
this you would call secondary resistance, because
Secondary
it is
resistance,
after 5 years of adjuvant treatment.
endocrine therapy. So
Yeah,
it
so
is
this is
secondary.
secondary resistance.
So we might consider for rechallenging with the same, I mean, AI in this case, and along with it, the CDK4/6 inhibitor to be considered.
Okay.
And regarding the selection of the CDK4/6 inhibitor, again, the side effects profile you should take in consideration. Okay, so what are the already existing, because she is 76 years, so she has got some kind of pre-existing comorbidities. We might consider these things, her cardiac effect and everything else. So these should taken in consideration, and again, then I will jump to select the CDK4/6 inhibitor accordingly.
Okay.
So if it is everything is okay, then obviously the OS data, again, the ribociclib would be my first choice.
Yeah. Okay. Okay. So Devopriya, if this patient was on letrozole, so would you want to change the patient from letrozole to fulvestrant, or would you want to continue letrozole and just add ribociclib?
I would change letrozole to fulvestrant and
Okay.
add ribociclib.
Okay. Okay, so I think probably the standard of care is CDK4/6 inhibitor plus endocrine treatment, and if this patient was on letrozole, probably we should change from letrozole to fulvestrant, and we should add CDK4 inhibitor and an effective CDK4 inhibitor, which we see is ribociclib, and there is a pooled analysis from Mona Lisa based on the age, and it has clearly shown that across all ages, even if the patient was less than 65, 65 to 75, and even more than 75, the OS advantage was maintained in all the different age groups, and even in elderly population, the OS data is better, and it is regardless of age. Ribociclib plus endocrine therapy has shown, even in the real world data like Ribana and complement also, that they can deliver consistently efficacy analysis like progression-free survival, TTP, and overall survival. Okay. Yeah, so this is the subgroup analysis, and there is also a Monarch 3 subgroup analysis of the overall survival, which shows that above 65 years of age, the overall survival difference is something that is not there as compared to less than 65 years of age, which reflects mainly on the tolerance and higher incidence of diarrhea that you might get in elderly patients when you are using abemaciclib as compared to younger patients. So this is something that is very important, that in elderly patients, probably we should prefer ribociclib more because of better tolerance and a better OS data, the subgroup, as compared to other CDK4/6 inhibitors. Now let us go to very interesting data about the visceral metastasis and aggressive disease. So Dr. Shushant, so when it comes to visceral crisis, so again, now there is clear data from both abemaciclib as well as from ribociclib of using CDK4/6 inhibitors. So again, which one would you prefer based on the data, and would you go with the right choice data of using ribociclib for visceral crisis, or would you go with the abemaciclib data for the visceral crisis?
very much comfortable with ribociclib because 90% of my patient on the ribociclib. I am very much comfortable with ribociclib with the practical experience. The only thing I always told, if it is liver visceral crisis with liver dysfunction, not only liver mets. If liver mets with liver dysfunction, then I will use abemaciclib. And and for other cases, any visceral crisis, I will use ribociclib.
Okay, okay. So I think this is the data of ribociclib with endocrine therapy. This is the exploratory data from Mona Lisa, and even in patients with liver metastasis, the hazard for PFS was 0.55, and the hazard for OS was also maintained at 0.77. And even in patients who had a mild liver dysfunction, so this was not there. And you can safely go ahead with using ribociclib in your patients, and this is the right choice data. So patients who had total bilirubin of less than equal to 1.5 times the upper limit of normal, these patients were taken and they had all symptomatic visceral metastasis. And against investigator choice of treatment, which was combination chemotherapy versus ribociclib plus NSAIs. So you can clearly see that there was a statistically clear significant improvement in the median progression-free survival as compared to the different chemotherapy regimens in the ribociclib arm. And these are the side effect profile, and we can clearly see that the incidence of grade 3 liver dysfunction was less than 10% as compared to the chemotherapy arm, where also it was similar. So these are not really something different. And just as Dr. Sushant said, probably in patients who have a very gross liver dysfunction, where we should be really cautious, but patients who have a very mild liver dysfunction, probably we can still go ahead and use ribociclib. Dr. Anuj, your thoughts on this liver dysfunction and the use of ribociclib?
So, first of all, I'm not using for all the visceral crisis patient because I hope most of you must also be very selective that it is not a generalized term that we are in a visceral crisis we can give. So that depends on the disease burden and also if and the age of the patient because we have seen that very young patients if we who are having shortness of breath or liver having multiple mets, these patients, if my personal experience is if they are not given chemotherapy upfront, then they deteriorate very fast. So, for especially young patients who are having pleural effusion, multiple liver mets, I usually start with the chemotherapy. But definitely, as you already said, that for liver metastasis patient also, I am comfortable using ribociclib. But again, careful selection of the patient is always warranted.
Correct. So there is again some data from Monarch 3 also and from the Paloma data that in patients who had visceral metastasis, there was no overall survival benefit. But if you look at the pooled analysis of Mona Lisa, even in the visceral crisis subgroup, the OS data was very much maintained. Now let us come to the last wing. Last few minutes, I would have want very quick answers. This is also again very interesting that post CDK4/6 inhibitor progression. Now this is a very practical problem. We know that there are multiple choices. HER2 low, we can go for TDXD. Somatic mutations like BRCA mutation, you can go to olaparib and platinum based chemotherapy. Chemotherapy is always there. Sometimes it works well. PIK3CA mutations, you can go with the PIK3CA newer drugs. Capivasertib is there, and then there are other antibody drug conjugates like datopotamab deruxtecan. NGS is the way. SERDs are the way, and if you detect ESR1 mutations, resistance pathway, this is something that you should sort of look into. But another important thing that has been explored in the past is re-challenging with CDK4/6 inhibitors. So, Devopriyo, what are your thoughts about the re-challenge with CDK4/6 inhibitors, and what are those patients where you actually go ahead with re-challenging with the CDK4/6 inhibitor and maybe changing the endocrine partner? What are the re-challenges you should, whether you want to use Abema or Ribo after Palbo, or you want to use Abema after Ribo, or you want to use Ribo after Abema or Palbo, and what are your thoughts about this, Devopriyo?
Generally, when the disease progression is not very, is not making the patient very symptomatic, and the tempo is not very aggressive. After a prior CDK4/6 inhibitor, then we have at least the evidence is there to change to ribociclib. If the first line CDK4/6 is
Correct.
either palbociclib or
Yeah.
abemaciclib.
So
The
there
only
are,
exception that
four
I really
studies,
follow.
Devapriyo, that has taken place. The maintain is one which has looked at ribociclib re-challenge. Post Monarch has looked at abemaciclib re-challenge. And Pace and Palmyra, they have looked at re-challenging with palbociclib. Pace and Palmyra has already failed. And Post Monarch and maintain, they have shown some success. But how would you, which one would you go ahead with? You clearly said that gross progression is something where we should not go with it. Mild asymptomatic progression is where you can sort of try this strategy. Correct. But which of the CDK4/6 inhibitor would you choose? The maintain data or the monarch post monarch data?
So maintain data has been there for some time, and I have used.
Yeah, I think we lost. They were Dr. Anuj. You want to make a point?
Yes, I think a lot many factors depends whether we are continuing with the molecule or changing the molecule. The most important for me is what was the previous PFS,
Hello.
whether the patient has the disease has progressed within 6 months or 9 months, or the patient has been taking medicine for 1.5 year or 2 years. So and definitely mutation we are testing to decide for the further therapy. And
Correct.
one
Because
of the things
longer is the
is also a
PFS.
common
Longer
because
is the
at times
previous PFS. It reflects more endocrine sensitivity.
and another thing is the commerce also because yes, that is the thing. And another factor is the common because most of our patients are poor patients and they get PAP for the ribociclib and it continues. Well, if we are changing the endocrine partner and ribociclib continues, so that is also a factor which we have to keep in mind. Although it is not a scientific thing to discuss, but that is also a factor.
Correct. So this is the cross trial comparison. We can clearly see post monarch and maintain, and the delta is what you have seen is that in abemaciclib arm there is a delta of 0.7 months only, but in the ribociclib re-challenge there is a 2.5 months delta, and we see that there was a longer PFS in the post monarch data as compared to the ribociclib, which indicates that maybe in post monarch there were patients who had more endocrine sensitive disease rather than the maintained data where the patients had more endocrine resistance, and probably ribociclib was had higher efficacy. But again, one thing is clear that once patients have progressed post palbociclib, we have both the options, maybe re-challenging with abemaciclib or re-challenging with ribociclib. But if the patient has progressed on either ribociclib or abemaciclib, probably then changing to another CDK4/6 inhibitors is not a very good option, and that is what these trials have also shown. So this is the maintained data, and you can clearly see that there is a delta of around 2.5 months improvement in the PFS that you can get with ribociclib when most of the patients had used prior uh, uh, CDK4/6 inhibitor, which was palbociclib, and in abemaciclib also there was a slight 27% reduction in the risk of progression PFS. But here this was there mostly when on patients who had used palbociclib and not on patients who had progressed post ribociclib. So clearly showing that ribociclib and abemaciclib are stronger ones, and palbociclib probably is the weaker CDK4/6 inhibitor. So I think we have had a very good discussion. The time is also over. So with this, I would like to summarize that we all have agreed beyond any doubt that yes, CDK4/6 inhibitors now are the first line choice of standard of care for our all advanced breast cancers, HR positive, HER2 negative, and even in visceral crisis, barring a few patients where we might prefer chemotherapy depending upon the pace of the disease, age, and the disease burden. There are differences in the on and off target binding and CDK4 and CDK6 inhibition, and these are the differences why ribociclib has shown better outcomes as compared to palbociclib. And survival, quality of life, they are the main goals. And ribociclib is the only drug, as per the Mona Lisa data, that has shown a significant improvement in the overall survival in first line across all pre-specified analysis, and regardless of menopausal status, regardless of visceral disease, regardless of type of resistance, and it has been a consistent OS benefit, even regardless of the age of the patient. And post progression on first line CDK4/6 inhibitors, continuing ribociclib sometimes can also give you an improved progression free survival, which may contribute to a better overall survival, that is there. So with this, I thank you all for a very good and active panel discussion, and over to the organizers. Thanks a lot.
Thank you, Vivek sir, for wonderful moderation. It's always a pleasure to have you. And I also thank the panelists, Dr. Devapriya, Dr. Kaustav, Dr. Susanta, and Dr. Anuj. Thank you, Vivek sir, once again. So next we have another panel discussion that will be again by Venkat sir. He's Director of Oncology, Sankara Cancer Research Institute from Tejpur, and he will be again doing a moderation, and the topic is role of medical oncologists from sample collection to NGS. Over to you, Venkat sir.
Thank you, Ashish. Thank you for the kind introduction. Please allow me to share the slides. Good evening. Dr. Vivek has done an excellent panel discussion now. So let us move on to a different topic of which is quietly a little bit of non-clinical, but very, very important. Every medical oncologist should know about it. So this topic is about a sample collection to analysis of an NGS sample, may it be liquid, may it be solid biopsy. What will be the role of medical oncologist, particularly with regards to pre-analytic and post-analytic factors? So let us move on to the topic. And we have our esteemed panelists today here, Dr. Nikhil Himtani, consultant medical and hemato-oncology from Delhi, Dr. Ravindra Kumar from Visakhapatnam, Dr. Chandrasekhar P. Singh from Ranchi. Dr. Nikhil, Dr. Ravindra, and Dr. Chandrasekhar, are you here?
Yes, sir. Good evening.
Hi, good evening, Dr. Chandrasekhar. Dr. Ravindra, are you here?
Sir, Ravindra sir will not be joining because of some unavoidable circumstances.
Okay. Dr. Nikhil, is he available? Dr. Nikhil Himtani? Okay. Let us move on to Dr. Paulami.
Yes, sir. Yes.
Yeah, good evening. Dr. Rajiv?
Yes, 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 sir.
Hi. Dr. Sanjeevan Patra?
Yes, yes, sir.
Yeah, good evening. Ms. Yashoda Raji?
Yes, sir.
Yeah. So we have enough number of panelists. So let us move on to the topic. So we do know that now NGS has become an important weapon in the clinical care management, without which we will not be able to treat certain number of cases, particularly breast cancer, lung cancer, and biliary cancers in advanced stages in particular. So there are so many processes that involve a good to get the output of a good NGS report from the time of sample collections to the transport to the fixation, proper analysis in the molecular lab, and proper analysis of the molecular report that is generated, and selection of the molecule. So this is quite a complicated and lengthy process. And today, let us delve into the factors where medical oncology should actively focus apart from analyzing the report and ordering the test, right? So let us ask Dr. Nikhil. Dr. Ravi is not available. Dr. Nikhil is also not available.
Sir, Dr. Nikhil sir has joined, sir.
Yeah, good evening, sir. I've joined.
Good evening, Dr. Nikhil. So the first question is for you. Just now we have seen how important and lengthy the process of the NGS from the point of collection to getting the report and analyzing it. So
Yes,
do you think it's really important that oncologists should overlook from the very beginning, let us say from the tissue collection stage,
where to send, who to collect, that also should be decided by medical oncologist. Is it important, Dr. Nikhil?
Yes, sir, I feel it is very important. And I think it should be even discussed with the molecular oncologist as well, because they have a major role to play. So, yes, sir, I feel it is very important.
Yeah. Thank you, Dr. Nikhil. So these are some of the pre-analytical factors that can affect the type of the report as well as the quality of fixation as well. For example, there should be adequate sample. We know that. Even from cytology, smear slides, we can do NGS, but we need at least 1,000 to 1,500 tumor cells. And they should be preferably 1 to 2 years old. They should not be from the archival bank where it is quite a decade old or so, or even 4 to 5 years old. And when we collect the blood for liquid biopsy, we should make sure that we are collecting an appropriate tube, which we will discuss in further slides. And the type of tubes we are sending for the germline testing, also depending upon the how many kilometers the or the how many hours this sample is going to be transported. All these also play a role. So, Dr. Chandrasekhar, uh, uh, you are practicing in Ranchi and I am practicing in Tezpur. So these are slightly peripheral areas. These are not metro cities. So some of the times you might experience that the tissue samples which we send may be suboptimal or inadequate. Where do you feel are the common pitfalls, particularly for molecular testing, when you get an inadequate report?
Yes, so as you rightly pointed out, most of the time tumor tissue is the issue. Most of the time they are depleted, not sufficient for further genetic sequencing. Pitfall being, I would suggest the technique and the number of cores they take for biopsy specimen. That is difficult, and the quality of biopsy sampling, that is also not up to the mark. In particularly if your radiologist is not that well trained, then it becomes a challenge to get good amount of tissue and further processing.
Yeah. Have you faced any time issues with the formalin, the quality of formalin?
Yes, sir. Most of the time, I struggle with this. Most of the time, the tissue is depleted, and they have, I think, issues with processing of sample as well.
Yeah. Also, while I am practicing in Tejpur, there has been issues regarding the number of days the sample is in transport. So, for example, some of the samples used to travel to Mumbai, some to Kolkata. So, when the samples are traveling from Tejpur, they have to go from Tejpur to Guwahati, Guwahati to Kolkata, or they have several stops in between also. They have to travel on road and then in the air. So, if any sample travels or is in the formalin for more than 3 to 4 days, it becomes overfixed, and even HPE reporting becomes difficult. And this is mainly important, particularly in the breast cancer, because the ER, PR, HER2 reporting can change, which will change the entire management. And of course, the molecular testing will become very, very difficult. So if we see the factors that are influencing the DNA and RNA quality while processing, obviously it's what is the buffer used for the fixation? If we are using a good neutral buffer formalin, 10% formalin or not. And even the wax, the quality of the wax that you used for the fixation in the block, that also plays a role. And the time of fixation, it should be ideally less than 3 days. And oxidation of tissue due to aging, if it is not properly preserved. And particularly when we are doing the biopsies from the bone, the type of decalcification we do, whether we are doing acid decalcification or whether we are using EDTA. And when big samples are being processed, for example, breast and all, what is the cold shipping time? What is the time before which it is placed in the formalin after being removed from the body? And the crushing and mechanical artifacts and so on and so forth. So these are the things that are in our hand. But there are some of inherent tumor defects which are not intended by the human. For example, when the biopsy done from the necrosis, when the tumor has a lot of mucin, when there is a lot of desmoplasia, stromal reaction, microabscess. So all these also can affect a histopathology report as well as the molecular testing, so that we'll need rebiopsy. And if we need rebiopsy, we have to again counsel, and it will need a lot of resources as well. Okay. So these are some of the factors which we need to consider. And Dr. Patra, you have been practicing molecular oncology. You are a molecular pathologist for a very long time. So, retrospectively, what do you feel are the common pitfalls? If we ask this question to you, because you might have seen some of the samples you received might be of very inferior quality.
Yes, sir. Good evening, sir.
Good evening.
Actually, what you have already elaborated those things, those are actually very common pitfalls. But for optimal specimen fixation, we usually follow the specimen fixation for that 10% neutral buffered formalin. That is the best for molecular analysis for FFP blocks. And another thing is the time of processing. That is, we usually follow that is at minimum of 6 hours processing and maximum 24 hours. That gives the optimum result. Sometimes we follow 72 hours, but 72 hours a bit delay. So 24 hours is the optimum. And for bony decalcification, we prefer EDTA or some weak acids so that the formalin, the DNA is not that much degraded. Those are factors we usually follow. And for other things, for liquid biopsy also, the anticoagulant of choice should be disodium or sodium citrate tubes, or sometimes nowadays a few cell-free DNA preservation tubes are also there, like PAX gene tubes. And for in those tubes, the sample usually is kept for a longer time.
So I would
And for
interrupt you, Dr. Sanjeevan here.
Yes.
So Trek tube and PAX tubes, are the same?
No, sir. EDTA tubes and PAX gene tubes are a little different.
No.
For
PAX gene tubes and Trek tubes.
stay almost same. Almost same.
So what is the component in it because of which DNA is stored?
Yes, sir. Actually, in these tubes, these contain some cell-free DNA preservation molecule, cell-free DNA preservation liquid, so that the cell-free DNA is preserved very nicely. And for RNA testing procedures, it can be even at room temperature. It can be stored for 3 days, and for DNA, it can be stored for 14 days. So those are better choices nowadays.
Yeah.
But for formalin fixation tissue, at least 6 to 24 hours fixation, and then it should be cut in thin microtome with 3 to 4 micron. And sometimes we follow one method that in slide we mark the tumor area. This tumor area, this is containing the viable tumor area, and we exclude the necrotic, neutrophil, mucin pools, so that from the block, when they cut the slide, they will take those amount of tissue for proper sequencing.
Understood. I would like to ask one more question to you, Dr. Sanjeevan. So recently there has been a new kid on the block called Instap is Preserve. So this is a solution which is an initiative of one of the startups from Bangalore. So they were saying that if we and some of the hospitals in South India are also practicing that already in Chennai and all. So what they are doing is saying is that this is a alcohol-free, formalin-free preservative. When they're keeping the sample, they're saying that it can be preserved for a year or so. So
yes, sir. Yes, sir. It can be. It can be preserved. Even if you take some tissue and immediately you place it in liquid nitrogen, or immediately you place it in dry ice, or even at minus 80 degrees centigrade, it can be preserved for years.
No, not that is. Those are the experimental techniques and which are available only in high-end setups. InstaPreserve is a simple liquid, just like formalin, but it is a formalin-free liquid. So
yes, it can be preserved.
Okay.
Yeah, I have also one question, if I may ask, please. Yeah. So just I spoke to the molecular oncologist. So I had a patient who had a pancreaticobiliary malignancy, and so the blocks are inadequate for NGS testing. So what they said that they can do that NGS testing from the slides as well, not from the blocks. So I've not heard it before. So if anyone could just guide,
Can
is
be
it
done.
how much?
This is the point I was
Yeah.
elaborating. So, cytology smear slides can also be used,
Hmm.
provided they are fulfilling this criteria. At least they should be 1,000 to 1,500 tumor cells, and they should
Hmm.
be at least 1 to 2 year old only, not before that. Then they will
Okay.
be able to extract the cells and they will be able to do NGS.
Okay.
Yeah. So obviously we know that in biliary cancers, to get a proper biopsy will be difficult. Some of the periampullary cancers
Yes. Yes.
will be able to get only slight tissue.
Yes.
So in continuation to that question, Dr. Nikhil, when you are sending such a very valuable sample to pathology, do you
Yeah.
give a signaling that to do a molecular sparing approach, that to do only HPE and not the IHC whenever if it is not necessary? Let us say HPE is already saying adenocarcinoma. Do you give a hint that please do not proceed with IHC?
No, sir. Generally, suppose if there is a liver SOL, then obviously we have to do an IHC to rule out whether it is an upper GI primary or lower GI primarily or metastasis or intrahepatic cholangiocarcinoma. So whether there is any doubt in the imaging, whether I feel it is some sort of an unknown primary, then definitely I do order this IHC. If the patient is having like a clear cut picture, then maybe I would skip if suppose the tumor markers are pretty high and the morphology seems like biliary, then maybe I would omit if the tissue is the issue. But generally in my practice, sir, I do limited markers at least to get an idea.
Yeah, I agree.
Yeah.
When there's
Mm.
confusion regarding the primary side,
Yes,
let
sir.
us say
Yes,
we
sir.
have taken a lung biopsy, the
Yes, sir.
tissue is space, and we do
Mm.
know that and lung is the primary with bone and liver metastasis and brain
Mm.
metastasis.
Mm.
Very clear radiological picture, but the tissue
Yeah.
is space. So
Mm.
in that case, when the pathologist is hinting that it is adenocarcinoma, and
Mm.
obviously we'll need tissue for the. So there is
Sir,
something called
if
as
the
molecular
morphology suggests,
sparing.
yes, sir, yes, sir. So if the morphology is suggestive of adenocarcinoma, I will discuss it with my pathologist if there is any doubt or query in their mind whether we should run an IHC or not. If they say the morphology it's look like adenocarcinoma, then I would obviously preserve that tissue for further testing, sir.
Yeah. Thank you. Thank you, Dr. Nikhil. So let us move on to the next discussion on liquid biopsy. So, Dr. Rajiv, when should we consider liquid biopsy? Uh, Let us say, will you use instead of or as a complementary test to the tissue biopsy? Is there any specific situation where do you want to send both liquid as well as tissue biopsy simultaneously?
If possible, like that would be my approach of sending liquid biopsy as well as tissue biopsy. But like this is not usually possible, especially in recurrent cases where the tumor is not approachable. Then liquid biopsy is an option. Also in patients who after multiple lines are not able to means are not fit enough to undergo a biopsy, liquid biopsy would be my choice.
So, can you give a scenario where you will like to use both liquid and tissue biopsy upfront? For example, a patient presenting with a similar patient, which we have discussed now, CA lung, brain metastasis, bone metastasis, because the HP itself will take 5 to 7 days on an average. So if we send a liquid biopsy also, we'll get molecular report by the end of 7 to 10 days in a good lab. So
Yeah,
are
in
you,
that case, in that case, a tissue biopsy would be of help, especially if we are sending, suppose, a EGFR allcross to a lab and getting the diagnosis beforehand and can start the treatment early.
yeah. So in such a scenario where patient might deteriorate in 1 to 2 weeks, sending both molecular first approach also will also help.
Yes.
So, Dr. Paulomi,
Yes, sir.
so
Good evening.
particularly if we want to use some specific fluid like CSF, compartmental fluid like CSF, pleural fluid, ascitic fluid, instead of blood, is there any special scenario where you want to send this liquid instead of blood for liquid biopsy? Let us say lung cancer, for example.
Yes, sir. For lung cancer, mostly we do from blood. Blood, we can send from pleural fluid also if there is malignant cell positive. In that case, we can send pleural fluid also.
Yeah. And also CSF when there is a suspicion of leptomeningeal mets in breast
Where
cancer.
there was leptomeningeal spread, if
Yeah.
CSF is positive, we can send instead of blood, we can send CSF.
Yeah. So while I was doing residency in Rajiv Gandhi, there was an Afghani patient who was a non-smoker who had a brain metastasis. Liquid biopsy came negative in lung cancer. He used to do liquid biopsy during that times as well, 10 years before. And he sent CSF as well as urine also. And urine sample was EGFR positive. It was quite surprising that urine may be positive aata hai. And CSF also tested positive and was started on osimertinib. So I'm not sure, but Dr. Patra, will you occasionally get such samples like CSF, pleural fluid, and ascitic fluid?
Yes,
for
yes, sir.
molecular
Yes, sir. Yes, sir. For molecular analysis, we often get pleural fluid and ascitic fluid, but urine I have not been encountered till now. But
Yeah.
CSF and other fluids we get.
How much of CSF is needed for the good molecular analysis?
So actually, it depends. Approximately,
Is there
I
a
think
minimum quantity like a 5 ml, to 3 ml, 2 ml?
I think 2 ml is enough.
Okay. For pleural fluid?
Pleural fluid in machine we usually process in for 50 ml. So I think that is enough for testing also.
So
Okay.
can I comment, sir?
Yeah. Yeah, please.
Sir, so basically, what I think in all those
Yeah.
oligoprogression patients, sir, in patients who are responding to other sites, but they are progressing on only to limited sites, maybe like CSF, or like in one ALK positive patient I had, the patient was responding to alectinib, but there was only recurrent pleural effusion. Okay, so in those patients, I would want to send pleural fluid NGS also, and we have data in EGFR also. In leptomeningeal setting, even 160 milligram osimertinib works well as compared to. So all those patients with progression, I would want to definitely discuss this option with the patient.
Yeah.
I have just one point to add. For fluid, I think that DNA quality will be always better compared to the formalin fixation.
Okay.
In that DNA quality will be very better because that is not exposed to formalin.
Yes. Also, as Dr. Ashish said, whenever the tumor is
if it's
when it is progressing in a specific site, in pleura, in peritoneum, there will be more amount of tumor cells there. So I think it will qualify the number of cells that are needed for the molecular analysis as well.
And the DNA will also be very fresh.
Yeah. Yeah. So this is also an important point. And Dr. Patra, can you elucidate and what are the samples, what are the test tubes we need to use, and what are the timeline in which we need to ship into the lab when we are sending such
I
fluids?
already mentioned it. We can collect it in disodium or tripotassium EDTA citrate vials, and also in Streck tubes or PAX gene tubes. Those can be collected. And if we collect in EDTA tubes, then the next step will be to separate the plasma as soon as possible. The longer the duration of stay, so the longer the cell-free DNA will be more, and because of the lysis of the leukocytes also. So as much as early as possible, it should be centrifuged to separate the plasma, and that plasma should be stored in 4 degrees centigrade, even in minus 20 degrees centigrade or minus 80.
Yeah.
And
So
for storage purpose, for transport purpose, it should not be very agitated, so that cell lysis will not be there, and it should be the temperature should be maintained strictly.
Yeah. So these are possible in the institutes, all the conditions, availability of the Streck tubes, transport within a few hours. But let us say we are transporting from very much peripheral areas. You mentioned EDTA tubes, which are cheaper than Streck tube because Streck tube is very costly, if I understand. It is not routinely available also, unless lab provides to the particular hospital. So when we are centrifuging to separate the plasma, are there any number of rotations you want to mention? Is there a specific centrifugation protocol?
Yes, sir. There is a centrifugation protocol. Like if for the first time, it should be centrifuged approximately 1900 Guy for 5 times. It should be centrifuged like that.
Okay. Okay. Thank you. Thank you. So, Dr. Polomi, you again. So now we have so many tests in the market, and within there are so many labs, and within some same lab also we have so much to choose from. There are organ-specific panels, there which are like hotspot panels. We have CGP, which tests more than 500 genes. We have which includes TMB, MSA, so many things. So let us say there are no financial constraints. How do you choose for a patient whether to go with the organ-specific panel or CGP panel?
Sir, if there is no financial constraint, we can go with CGP panel, where we can found more number of mutation. But mostly patients have some financial constraint, like if there is a lung cancer patient, metastatic lung. So mostly we should take at least 12 gene panel. But yes, if there is no financial constraint, we go for complete 60 panel.
Yeah, yeah. So most of us, as a medical oncologist, we tend to do as large panels as possible. But let me play a little bit of devil's advocate here. There has been ACMG and ESMO statement which states that ideally we should go for a hotspot panel whenever possible in some of the malignancies, and expanded NGS indications have been very, very specific as far as ESMO is considered. And in fact, they say that if we do a very large panel, it should be discouraged in particular. So, Dr. Patra, any comments on that?
No, sir. I think what we usually get for lung panel, it is already like a hotspot panel, like a Presico lung. It is like that. Mamma print, it's like that. But for I think if someone wants for bigger panel, like 161 gene panel, something like that, then he can go for that.
No, I agree, but as a molecular pathologist, would you see any specific advantage of hotspot panel versus CGP in terms of TAT, in terms of depth, in terms of?
Yes, sir. Yes, sir. For hotspot panel, the depth will, I think, it will require less depth and less coverage, and it is already prefixed, and the TAT will be less. Definitely, TAT will be less.
Yeah. So when we require a quick report and the patient is very much symptomatic, maybe we should choose a hotspot panel so that we will get a quick report if possible. So choosing when the options are more is slightly difficult, but this is how I think we need to act. If there are any comments from Dr. Nikhil, Dr. Rajiv, Dr. Paulami, and Dr. Ashish regarding this, you may chip in. Dr. Singh.
So basically, I would, in all those primaries where we have different targetable mutations, you talk about lung cancer, you talk about BTC, even colon for that matter, I would want to go for a comprehensive NGS panel if money is not a problem, because I would want to have the molecular signatures in front of me before starting the plan of the. It not only helps me to prognosticate, it also helps me to sequence the different line of treatment which I can provide to the treatment. So if money is not a constraint, definitely in the sites where we have different targetable options, definitely I would go for comprehensive NGS panel.
Yeah. So I agree with Dr. Polami and Dr. Ashish. Definitely, as a medical oncologist, we would like to have more amount of information before us so that we could determine whether the patient is fit for targeted therapy or fit for immunotherapy, so on and so forth. So, Dr. Raju, can you take this question? Like, are there any cases where you want to send only DNA-based testing, or you generally send for such a NGS test which would cover both DNA and RNA?
Actually, like sending a DNA plus RNA NGS testing would be my choice, because like fusions and all are not are very well detected in the RNA testing. But in my practice, we usually go for a DNA testing, like to most of the labs.
Only DNA testing.
Yes,
Are
means
you-
most of the like the NGS panels in our country are mostly DNA based.
Okay, okay. So particularly when we are doing panels such as lung and all, I think we need to consider both.
Yes, because fusions, yes,
Yeah,
ALK
all
and ROS, they
crossbred.
won't be well detected. Yes.
Yes. So when we see the coverage and sequencing methodology while choosing NGS, particularly that we do know that there are two types of NGS that are commonly practiced. The Thermo Fisher platform and Illumina platform, two are the most common platforms that are used worldwide. And the type of sequencing, when we see the type of NGS that is done, one is amplicon based, that is, and then hybridization method. So, Dr. Nikhil, do you see all these factors while choosing NGS, or do you choose only good lab and discuss with molecular pathologist which test to send? Do you have a prefixed menu for a particular cancer, which NGS to send? Dr. Nikhil, are you there? Dr. Singh?
Yes, sir. So it is difficult for us to decide. Most of the time, we see the reliability and the quality of reporting of molecular lab. And as you rightly pointed out, DNA versus DNA plus RNA. Ideally, both DNA plus RNA based NGS should be done. It will give you an idea about expression of any sort of fusion or mutation. So basically, it is like a music concert, DNA plus RNA versus DNA. DNA is relatively stable. It will give you an idea about the script, means there are fixed things, whether deletion, copy number variation, mutation. But RNA will give you an idea about music streaming, means live streaming, whether these things are expressed or not. So DNA plus RNA is the way to go. But whether sequencing methodology, we are not into not much into that thing. Most of the time, I see the reliability of molecular lab.
Yeah, I agree, Dr. Singh. So, Dr. Patra, can you, for us as the group of medical oncologists who are here, can you describe amplicon versus hybridization method NGS, which is usually preferred?
So, what we usually see, mainly we follow the amplicon method, where the stretches are red per amplicon. Hybridization method, I think it usually we do it not very commonly. Usually we follow amplicon based methods.
Okay. Is there any advantage of one method over the other?
No, sir, I don't think so. That is amplicon. We usually it is and in the many platforms they are based on predominantly amplicon methods.
All right. So, Dr. Ravindra is not there. So, Dr. Sanjeev, this is again for
One thing
you.
to add on. I think Joshodhara madam will highlight something regarding this. Being a scientist.
Thank you, sir. So, sir, yes, there are both of the techniques have their unique advantages. So, amplicon methods, like Dr. Patra rightly mentioned, is more used for hotspot regions because those are the known mutations and the primers are made in such a way so that even at a low sequencing depth, you're able to pick up. That also kind of manages the cost and the detection as well. But hybridization methods becomes important when you're doing a complete gene sequencing. Because in cases where maybe you're not getting something on hotspot, you're seeing that a patient is progressing. In those cases, complete gene sequencing will be important because probably that patient has some newer mutations which is not part of the hotspot panel. So that is where the hybridization method is truly important because it covers each region. The probes cover the regions in such a way that they are well mapped, and with a higher sequencing depth, it gives a much more reliable result. So it's based on, again, what the clinician is looking for based on the cancer type of the patient.
Yeah. So basically, if we are looking for the hotspot panels, it is amplicon based. If we are looking for the whole exomic sequencing, whole DNA, whole genomic sequencing, then it is hybridization. Am I right, Mr. Shudhar, ma'am?
Yes, sir. Yes. The
Yeah.
complete gene sequencing is better done at hybridization method, but again, depends upon the clinician's requirement at the time for the treatment.
So there's a lot of discussion about the black box sequencing these days. So black box sequencing is hybridization, if I correctly understand. Is it correct?
Right.
Yeah. So black box sequencing is are the missions which companies give to the labs. We don't know what exactly happens inside, but they'll give a prefix output for the number of genes. We can tailor it as per the need, and they will give the output, right? So, Dr. Patra, again, what is the minimum acceptable coverage for the representative variant? For example, if I am sending a sample for lung, EGFR all cross. So, what should be the number of minimum coverage for that particular variant?
Sir, actually, there is nothing like that minimum coverage, nothing like very absolute number or point like minimum acceptable coverage. But in CAP, College of American Pathologists and American Molecular Pathologists, they usually prefer at least 50 times coverage for any germline mutation and at least 250 times coverage for any somatic variant mutation. This is the minimum acceptable coverage.
Yeah. So for germline, it is how much? Sorry.
At least 50 times.
Yeah, 50x. And when we do liquid biopsy, the depth of coverage would be many thousand times because we need to extract DNA from the lot of noise in the background. I think what it would be around 10,000x. Is that the minimum coverage for the liquid biopsy?
Yes, sir. At least 5,000x.
Yeah, yeah. So there has been, like, when we see the reports, we see a lot of parameters, but one of the most important parameter we look at is VAF when we are determining whether to act on it or not. So what is the difference between a reported variant of a VAF of 1% when the depth of sequencing is 10,000x, like we are discussing now, versus 100x? Let us say it is for the same somatic variant in a tissue biopsy. So if the VAF is 1% at 100x sequencing as well as 10,000x, how should we interpret it?
So, if in 10,000x, the chance of false negativity will be very less. Because if I am giving the coverage is high, then chance of detection is very high. So minimum length of allele frequency, minimum length of variation, that will be picked up in 10,000x coverage. But at 100x, that coverage will be less. Even it can be false negative.
I understand. It can be false negative, but as a medical oncologist, if I understand, see, if at 100x, if I am getting a VAF of 1%, I expect it to be more frequent. Then at a 10,000x, if I am getting only VAF of 1%, I expect it to be there. So will it be more significant at 100x compared to 10,000x?
So that I think that will also depend on the allele variant. If it's pathogenic or it's not pathogenic, likely pathogenic, that will also depend. If I get even it at 100x, then the tumor tissue, the allele frequency is more.
Okay. Ms. Ashodhara, Dr. Ashodhara, do you have any comments on this?
Yes, sir. So I agree with Dr. Patra. So what happens when we do a sequencing with a high depth? So in a tumor, again, there are subclonal populations, there could be different clonal populations. And we understand that in somatic cancers, even a small percentage of cells with even an actionable variant or a clinically relevant variant is important for the clinician to understand the mutation signature, how to process ahead, what needs to be done. So when we do it at 100x, then the number of reads, that means how many times I'm reading that mutation is lesser, because that 100x is actually being divided into the entire region of the code which is being checked. So the more number of reads I have per mutation, the confidence is higher that this mutation is truly positive and it is not a false positive due to background noise. Because no matter what happens, even with the best sequencing technology, there could be some background noise. And at the end of the day, the background noise sometimes cannot get filtered out if it is at a lower depth, specifically when we are doing a tissue testing.
Understood. So, as I understand, I think this is like reading a book. For example, if let us say there is a novel with a hardcover, the front, back, acknowledgements, and the main content. So in hotspots, we are reading the important chapters. That is the coverage we are looking at. And whole exomic sequencing is we are reading the content, leaving along the acknowledgements and the front and back cover. And in the whole genomic sequencing, we are reading from end to end, from front to back. So that is what I understood is the coverage. When we say the depth, it is number of times we read that book entirety. So if we have a hotspots panel, like if we are reading specific chapters, we can read so many times easily. So that's why hotspot panel will pick up if the mutation is present very easily. And that is how it is. The coverage and depth is what I understood. So when we see the variant allele fraction, this is the fractional proportion of the sequencing reads, which represents the specific allele relative to the whole of the genes that typically represented as a percentage, right? So Dr. Ravindra is not here. So Dr. Himtani or Dr. Singh, if you can take this question, when we see the interpretation of WAF, is it a measure of disease burden or only important as a measure of coverage? For example, this is one of the report of liquid biopsy of a patient who has progressed on first line Jefnib plus Pemcarbo, right? So this patient has not done biopsy initially. Pleural fluid cytology cell block was done. EGFR was positive. He was given Jefnib plus Pemcarbo. Now he progressed. Number of bone mets and lung mets have increased. And so liquid biopsy was done. And this is what we got. EGFR del 19 was present and WAF is 0.51% and KRAS mutation is present. We actually looked for T790M, but it is not present. KRAS was present. WAF is 0.85%. So is it really relevant? So Ms. Ashodhara, can you chip in for us to understand?
Yes, so like we discussed even in your previous slide, that tumor heterogeneity does play a role. And when we are doing a liquid biopsy, that time it is essentially representative of the different tumor paths, the ctDNA, which is pooled. So even a smaller percentage, whatever we get actually may be relevant because we are looking at a lot of ctDNA, we are accumulating it and sequencing at a very high depth. So in that case, it is representative of the tumor heterogeneity. It can give the clinician information regarding the tumor mutation signatures and also depending upon the limit of detection and on the sequencing depth which has been done, we can say whether or not this WAF would actually have a relevance with respect to the disease burden as well. So as important as it is as a measure of coverage, it may also at that time be a measure of the disease burden as well.
Okay.
Ma'am, can I ask one question, sir? Venkat, sir. This is Dr.
Yeah.
Chandrasekhar. So, many a times we see a particular mutation or genetic aberration having WAF of, say, 2%, 3%. So, should we decide our treatment? Does it, can we take therapeutic decision based on such a low WAF? Ideally, if you're getting WAF of more than 50%, then it is very strongly recommended. Even if it is more than 10%, then you may take therapeutic decision based on such WAF. But a WAF of 2%, 3%, should we take therapeutic decision based on those reports?
Yeah, before I ask Dr. Yashodhara, Dr. Patra, so it is very important question because these are the discussions we usually have in the molecular tumor board as well as in the groups, medical oncology groups. I think, yeah, so the WAF, as Ms. Yashodhara has said, it depends upon the depth of the test. We also need to see the depth of the test that was done along with the WAF and the type of the test. Is it a liquid biopsy or is it a somatic biopsy? So if it is more than 50%, most of the time it also signals it can be a germline alteration as well. For example, if there is a BRAF alteration, if there is a BRCA alteration, and it says WAF is more than 50%, it might hint that we might need to do germline testing. This is what my understanding is. Now, I would like to ask Dr. Yashodhara, if you so I would like to ask that question posed by Dr. Chandrasekhar Singh. So WAF, does it signify clinical actionability or not?
So, I mentioned in the previous answer also that because based upon if it's a tissue biopsy or whether it's a liquid biopsy, depending upon the limit of detection, and this is purely from the technical side that I'm being able to say this, that we can say whether or not this is truly representative of the tumor heterogeneity. However, the treatment decisions again are the medical oncologist forte, so probably I may not be the right person to answer this question. Maybe Dr. Ashish or maybe Dr. Patra may be the right people to answer this question.
So basically, I had one patient of CA lung only. I wanted to discuss the VAP. The patient had EGFR exon 19 deletion positive, and the VAP was 1%. And even I called Yasudhara man and I discussed is it relevant or not. Then we discussed that option with the patient. The patient was initially started with chemotherapy, but after that we again switched to FLORA 2. But then, due to thrombocytopenia, the patient is now only on osimertinib and doing well for the past 8 to 9 months. So even with VAP, that patient had VAP either 1% or 0.1%, if I'm not wrong. I cannot actually recollect.
0.1%, sir.
0.1%, yes,
0.1%.
exactly.
Yes, sir.
That patient had 0.1%. The patient is doing well on osimertinib for the past 7 to 9 months, if I'm not
Was
wrong.
it a liquid biopsy, Dr. Ashish?
It's both. In lung cancer, I said both, sir. Liquid plus solid. That's a standard for me. In all lung cancer patient, I sent solid plus liquid.
Okay. Dr. Patra, your inputs on this VAF?
Sir, I have not a medical oncologist, but still, what I think the dominant mutation should be covered first. The VAP with more percentage, unless that sometimes we get mucinous adenocarcinoma blank, so where we know that the KRAS mutation is prevalent. So in except those cases, the EGFR VAP is 2%, 3%, EGFR exon 19 mutation. I think that should be covered first, and even after recurrence, if the patient recurs, then the other mutation can be seen. But I feel, I don't know the exact perspective medical oncologists, but I feel like that.
I understand. So, Dr. Nikhil, any inputs? Dr. Rajiv, Dr. Polami on this? Okay, so these are the points usually that are discussed in the molecular tumor board. And to my understanding, for certain genes, there has been a VAF level beyond which they are significant, and they are available in the literature. So when we see the variant classification, they will soon after we prepare the library, we compare with the standard genome, that is CHGR37, and we'll report based the variants comparing to the standard genome we had for the comparison, and then we call upon the variants. So these are the categories of variants we usually see: the pathogenic, likely pathogenic, variants of unknown significance, likely benign or benign. And this is the SCAT scaling, European Society of Medical Oncology scale for clinical actionability. If it is type 1, we are ready for routine use. We can upfront start the therapy. And if it is type 2, it is somewhat investigational. If it is type 3, type 4, they are hypothetical targets. And if it type 5, type 6, ideally we should not use. And sometimes we'll get stuck up with this type 1 and 2 level B findings, how to practice that. So these are the actionability by levels of evidence. So level A is the FDA approved therapy where which are already included in the professional guidelines. Level B is well-powered studies, so we can still go ahead with the therapy. When we say level C, there is FDA approved therapy for the different type of tumor with the multiple small studies, etc. So we have seen this discussion already. One important question I want to pose as a genetic counselor, Dr. Yashoda, is do genetic counselors have a role to play in the pre-test and post-test counseling of NGS carried for the targeted therapy option of the patient, not the germline testing?
So, sir, for this question, essentially, usually because the tissue or liquid biopsy testings that we do, those are absolutely targeted for therapy or immunotherapy options for the medical oncologist. And usually genetic counselors don't really have a lot of role to play in the pre-test counseling part. However, we do know every patient is different. Some patients become very anxious. They have a lot of questions. So in those cases where maybe the clinician feels that they need maybe a little more support in understanding the test, that is when maybe a genetic counselor can play a role in the pre-test counseling. Post-test counseling, again, it is more of a supportive role. It's mostly genetic counselors play a role when it comes to germline testing, or say there is a somatic variant with a high VAF. So in those cases, whether or not germline testing may be required, the clinician may want us to take a detailed family history to understand whether or not germline testing should be done for this patient, or even in certain cases where the clinician feels that, okay, there's a family history, I'm seeing maybe a BRCA variant, but at a lower VAF. Do I need to get this done for this TNBC patient? So in those cases, again, in such cases, we can be a supportive help to the medical oncologists and clinical oncologists for them to help their patient maybe come to terms with all these difficult jargons which come in, to understand why this test is being done, maybe, and specifically because if we are considering a germline testing from a somatic VAF related finding that we have, then maybe to support them in that to understand why now another testing is being done and why do I need to submit another sample. The clinician, my doctor was telling me that probably my family may need to get tested if I come positive. So these are very small questions, but often or not, they tend to kind of make the patient anxious. So in those cases, wherever the clinician feels that a particular patient may require that added little support, I think genetic counseling can be helpful for those kind of patients.
Yeah, yeah. Thank you. Thank you, Dr. Yashudha. And moving on to the final slides, these are the ASCO guidelines for germline gene testing panels, where patient should have family history, more than one gene is relevant. Multi-gene panel should be offered when we are suspecting when there's a strong family history. And the panel should include the strongly recommended genes, definitely. There has been some genes, particularly in breast cancer, ovarian cancer, which are recommended and should be included in that panel. And also, a patient who meet criteria should be offered germline, regardless of the tumor testing, regardless of the tumor type. These are all, to our surprise, in fact, GIST, melanoma, sarcoma, also germline testing is recommended as per the ASCO. Even NCCN recommends almost similar. So there has been very wide recommendation for germline testing, and there has been panels in various labs as well. And these are the attributes based upon which we will get the pathogenic, likely pathogenic, VUS, likely benign and benign. And again, VUS becomes a dilemmatic state for the clinician as well as the patient. We need to follow up with the lab, and because every 6 months we need to follow up and know whether it has become pathogenic or not. This is quite a tedious procedure. Some of the labs do follow VUS, and by calling up the patient and they inform them. Right. So coming to the closing remarks, definitely medical oncologists have so much of role to play, from the pre-analytic factor to the post-analytic factors, to the analysis, to the selection of targeted therapy. With this, I'd like to end my talk and hand over to Dr. Ashish again. Thank you for giving this opportunity.
Thank you, sir, for excellent moderation. This is a very complicated topic, and you have covered this topic very well. And sir, regarding your last question, you asked about the role of genetic counseling in pre and post counseling. Again, last month we had a case. That patient was a COV patient. The patient's daughter was a doctor. She was curious to know about the germline testing and all. We all recommend HRD and BRCA testing. And in fact, before the test only, she only asked me to have a genetic counseling opinion. And even I think Jasudha ma'am only counseled that patient. So luckily the BRCA came positive. It's negative, but yes, definitely it's just because it's MDT. It's very important to keep everyone in the loophole, and so that comprehensive treatment can be provided to the patient. So that again is very important, sir. Thank you once again, Venkat sir, for excellent moderation, and to all my panelists, Dr. Chandrasekhar, Yashodhara ma'am, Dr. Sanjeevan Patra, Dr. Nikhil sir, Dr. Rajiv, and Dr. Polomi. So with this, I think we have come to the end of our Onco Talk Part 1. Hopefully, we'll have another one in coming month, or maybe after a couple of months. So special thanks to the entire team, Avni, Jhalak, and Mr. Tarun, without whom this would not have been possible. And also the special thanks to my sponsor, Ross, AstraZeneca, Novartis, Vansel, and Reddy's. Thank you once again, everyone, and good night.
Thank
Thank
you.
you
Bye.
so much, sir. Thank you.
Thank you.